If people could start coming in and taking their seat. I just want to remind all presenters to take an assigned seat in the front row.
You're explaining the questioning process.
Sure, I've never heard it before, so I don't know. Okay.
All right, we're going to get started because I want to make sure that everybody is able to get out on time to make their flights. So for the panel and for the speakers, so this is the time where the panelists, if they have any questions, that they can ask any of the speakers those questions. We have an hour, so hopefully we can keep our answers, succinct as best as possible, so that we can get through everybody's answers and all the panelists' questions, so that they'll be able to answer our 23 questions at the end of the meeting. All right.
Great. So at this point, I'll just open it up to the committee to see if anyone has questions for the presenters.
I have a couple of questions. One is for the panel members or for the speakers. Do either of the existing CAR-T therapies that were approved by the FDA have a labeled claim for PRO outcome? So the FDA has a very clear set of standards for PRO outcomes. Have either of those products had a labeled claim that reports PRO data, or do they have PRO data reported as part of their clinical trial endpoints in the label?
Again, Will Go from Kite. We do not have any labeled claim, to my knowledge, in any of our USPI for PROs.
Okay, thank you.
Novartis also does not have any labeled claim with regard to PROs within our U.S. label.
Okay, and do you have it in other labels?
Within our European label.
Excuse me, could you please state your name for the record?
Sorry, Corey Abacoff from Novartis.
Thank you.
Within our European label.
Okay, can you?
I can't speak to the specifics.
Can you suggest as to why it's not in the U.S. label versus the EU labeling?
I don't have access to that specific information.
I have another question. In terms of the CAR-T trials, what % of the patients were both sponsors mentioned that in the pivotal trials PROs were used. What % of the patients failed to complete scheduled assessments at scheduled time points, potentially because of toxicity or something? And how did you address that in terms of respondent bias, if you address that?
I'm going to actually ask Dr. Leah-Farusi to answer that question.
I just want to remind speakers at the mic, because I've been told the same, please speak up so everyone can hear and the mic picks up the things.
Thank you. Aaliyah Farusi with Novartis. I don't have the exact percentage, and what I can tell you is in the Juliet study, analyses of the PRO data, we focused on patients who did have a complete response or a partial response there, because that's where we had data to analyze.
Okay. Yeah. Thank you.
Will Go from Kite. In our pivotal ZUMA-1 study, it's a single-arm design, so we did not do any prospective PROs in cohort 1 and 2 of the pivotal study, which was the data that was used for the label enabling of the USPI. We then incorporated PROs as exploratory endpoints in additional cohorts of Zuma 1, such as in cohort 3. This has not been reported out yet, but this is one, so we don't have the data on hand, but this is obviously one of the challenges that we, as other speakers have said, in terms of collecting missing data. As I said on the podium, Zuma 7, our randomized controlled phase 3 global trial, we are collecting PROs prospectively, and it is a secondary endpoint.
Okay, thank you.
I'll suggest this question. Is it Dr. Bosch? Am I pronouncing it correctly? First, I'd like to thank you for a very cogent presentation of the different PRO tools. Anytime I see 7 of anything, I know one of them's there's not an ideal tool to provide the information. So what I'd like to ask you, what suggestions might you have in terms of improving the patient-reported outcomes process, since we have 7 different instruments to look at? Well, what would you do to come up with 1 or 2 ideal instruments?
Hi, Ethan Bash from University of North Carolina, responding to the question. So do you mean in this particular population or in general?
Well, I haven't seen any, it's a whole area for discussion, so I'm assuming, I'm going back to my experience at Rutgers Medical School, where we had a very robust end-of-life care. So patients would make decisions based on how much pain they were having, how much sleep they got, who in their family they spoke to. So I'm sure there's diversity in genders, there's diversity driven by cultural backgrounds, ethnicity, social economic status, educational status. There's a whole list of variables that we could factor into how patients report their outcomes. And I'm clearly not an expert in that field. So if you had to come up with an instrument, what additional questions or parameters would you want to look at?
I think it's a nuanced question. I'll do my best. And Dr. Klutz from the FDA may also have some insights on this. In terms of putting together a tool that would give us insights about how people feel with this therapy, I go back to something that I mentioned, and Dr. Klutz did as well, that physical functioning is very important. Now, physical, a lot of people have talked about, oh, we don't know what tools we can use yet, and we have to go back and, start at first principles. It's not the case for physical functioning. Physical function is physical function, right? I mean, I see patients getting all kinds of therapies with all different diseases. Physical functioning is pretty uniform, and there are excellent tools that are already available, some which are on your list. The ERTC QC30 has very good physical functioning. PROMIS has very good physical functioning. I think those are ready now, and in an assessment, I would absolutely include that, number 1. I think number 2, I would let patients self-report their own side effects. We know that this is, it's not that it's underreported, it's just that we miss a lot of stuff and we misattribute. Patients know better than we do as investigators. So I would absolutely include symptomatic adverse events. And to figure out what adverse events are important in a given trial, that's really dependent on the products that are being tested and what's known about those products and hypothesize. And over time, as we accumulate experience, we start to know, okay, which ones should we ask? And those get loaded into a form. So now you've got a form, it's got physical function and a bunch of side effects, right? And then the third, I think, which is more challenging, and Paul Klutz can comment on this, is disease-related symptoms. I think that's a little more challenging in this context, but that could be considered. I'm going to put that aside for a moment. And then the final piece is overall quality of life. And that includes some of the domains we talked about, emotional or social functioning. And we already know that. And that stuff is generic too. That cross-cuts diseases. And so I think that you could put together a tool. You and I could do it on the back of a piece of paper, like after the meeting. We could just, put down those domains. And those actually would probably be pretty reasonable as a start from where we are today, okay? Now that said, I think that it would be useful to take a step back and go to the population and really talk to people and see, what symptoms and what things are really an issue for them. And then, you could go to version 2.0. But I think that, we're ready now to measure things that are meaningful to people that most likely will detect signal.
Dr. Shah? Oh, I'm sorry.
Surabhi Sadana from Mayo Clinic. I think just as a comment to that, we are also using Pro-Ctcae, but the challenge is there are 78 questions, and I had to, based on my clinical judgment, pick which 20 of them. Now, my colleagues who are using Pro-Ctcae may pick another 20. And right now, my patients who are filling out the questionnaire, it's already taking them 45 minutes with 20 questions. Now, did I get all of the right questions? I think that's where the prelim data comes in, like which questions exactly. And we'll know which questions are changing over time and talk to patients who had CAR-T. Okay, what was important to you? What symptoms did they have? What is important? So I think we need that data. And I think one thing which none of us talked about is a lot of these people get neurotoxicity. Like about up to a third can get that. So we are testing questions for cognitive function. Do they recover their cognitive function? If they had neurotoxicity, do they still have cognitive impairment at 6 months, 12 months? I think that's important to address because it may be subtle and we need to pick it up. Thank you.
Let me ask one other question before you go. Because I haven't heard anything. You mentioned that people have to come to certain centers because not everybody is providing CAR therapy. So if you're talking to Medicare population on a fixed income, what about ancillary considerations? How do people factor in financial burdens, ancillary cost in terms of their decision and how they're making the decision to commit to a new therapy where the outcomes may or may not be desirable? There are considerable side effects to take into consideration, and there's some economic considerations that may impact other family members or the member themselves. Is that part of the assessment?
So that's not part of our assessment for this study. We are doing another study where we're looking at people enrolling on trials or not. And a lot of people don't enroll on trials because coming back and forth to a center, it's more money, it takes time, somebody has to take time off from work. But I think it's an important question to ask. We are not collecting that information right now, but it is important, especially if you're going to mandate someone collect questionnaires or come back to follow up to a referral center. Well, who's paying for that? Who's paying for their caregiver to take time off? I think those are challenges, and I think need to be addressed.
Okay. Dr. Klutz, were you going to stand up? Just want to make sure you have it.
Yeah.
Hi, this is Paul Klutz from the FDA, and I just want to address a couple things. The first was a little bit about labels, FDA labels versus European labels, and what's the threshold for data regarding those two different ways to communicate. And Europe definitely has a different threshold for what to put in their labels and how to put it in. They have different regulations, et cetera. For our labels, especially if you're making a claim of treatment benefits saying our drug reduces pain, our drug improves health or the quality of life, it needs to be statistically tested, substantial evidence, and that's not frequently done. They're typically not incorporated in the statistical hierarchy and tested in that fashion. But we have many examples of using descriptive PRO data in labels to sort of further describe a therapy. And so I was just jotting down a couple of the more recent examples. For safety, which I think kind of is interesting in this context, crizotinib, which is a really important lung cancer therapy, was known to cause ocular toxicities through normal clinician report. And ocular toxicities is somewhat unusual, and so they wanted to get a little more information about how that was really actually affecting patients. So they did incorporate a patient-reported outcome specific to that. And in the label, it notes that, yes, there was a lot of ocular toxicity, but patients did not feel that they were bothered by it, and there were several other facets of it that were from the patient that really gave, I think, a lot more information about that toxicity. There's several efficacy examples, and one where we did actually have a lot of flexibility in what we would normally accept would be the Hemlibra label as far as improvements in function and joint pain. And that was, it was statistically tested, but the instrument had some flaws. So we do put this data in labels. I would say on the other question, which is what should we do with respect to if we could tailor something right now, I agree with Dr. Bosch. I think physical function is a very, as I mentioned, disease agnostic type of measure that's going to be pretty applicable. There is some finesse in there because you do want to make sure you have your where you need to be in your scale, because if your baseline function is very high, like in a female adjuvant breast cancer trial where there's young women that are actually functioning very well, you might want to add a couple higher functioning items on there to capture that level. So there's some finesse in it, but I think physical function is important. I do think wearable devices in addition to PRO in that physical function domain is going to probably be something that's going to be very valuable in the future as well. And then finally, for the value of symptomatic adverse event reporting by patients, one of the things that we're looking at that I think is going to help, especially in single-arm clinical trials, is we have a very hard time understanding what's actually disease and what's actually treatment-related side effects. And the way FDA does it currently is we don't look at the attribution that the physician gives to the AE. We just assume it's due to drug because we don't really know how else to do it. So you'll see in phase 1 trials, early accelerated approvals, like 80% fatigue, very high levels of fatigue, which you know is probably was there at baseline. What you can do with these PROs is you'll get a baseline measure, and then it'll be systematically assessed. And so you can take baseline into consideration. We're looking at ways to say, we're not going to call it a drug-related adverse event unless it goes above what it was at baseline. And I think Amy Lou Dweck from Mayo has done some work on that too. We're exploring that. We think that could be valuable to sort of cut through some of the fog that we see in these single-arm trials, where if you really want to talk to your patient about what they might experience, you know, it looks relatively significant. There's high levels of symptomatic side effects that may or may not be attributed to the drug.
Can I just follow up to that? On that point? One of the things that you mentioned on the slide, you categorized, besides patient-reported outcomes, you had, I think you called it observational reported outcomes, and you noted that that may be but from the caregiver, for example.
Yeah.
Do you really view those to be two separate measurements? Because I imagine, certainly with the pediatric population, and we're discussing the elderly population that is very ill and is undergoing this therapy, they're typically going to be accompanied by a caregiver, a loved one, their spouse perhaps, that will be able to provide insight for a PRO that they may not be able to do on their own. So it would seem to be inherently part of a patient-reported outcome rather than a separate category. Am I correct with that? Or?
Yeah, it's a subtle point. I think what you might be referring to is what we call proxy reporting, where it's someone other than the patient filling in the same questionnaire that the patient was supposed to fill in. We don't actually, FDA is not a fan of that. Our clinical outcome assessment staff doesn't like that. Rather, for infants or say someone with brain tumor or major dementia that is unlikely to be able to fill out the form themselves, they would look for observable signs that the care provider can record. And that's a little different because you don't get that non-observable nausea type of pain thing that you can actually observe. So in those cases, you get diarrhea, you get activity levels for kids. And so that's kind of the way we've looked at it. Observational reported outcomes need to be observable signs.
And how do you tease out things like financial toxicity, as it's phrased, or general anxiety because they're grappling with a serious illness, versus that being specific to the therapy involved?
Yep. I try to make it clear that there is no perfect way to tease that out completely. Symptoms are probably the closest to the drug effect, as I said. And even within symptoms, teasing out whether it's a drug-related symptom or a disease symptom, or even a symptom that is a comorbidity, is unclear. Now, that one thing that we tend to do is hold PRO to a higher standard than we do any other clinical trial measure. We know that Ctcae also suffers from the same challenge. So, yes, I think teasing that out is a challenge.
How much do you think that biases the actual measurement?
Which part of it biases it?
Well, in the sense that there can be an increased, let's say, whatever it's specifically being measured, let's say anxiety, and you're saying, well, that's because, look at it related to the drug. Do you use a baseline comparative to other patient populations to be able to say, well, this is something that we see consistently with other therapies and other patients that are undergoing therapies for serious illness, and we can actually deduct that from our overall evaluation? This is actually set aside from that benchmark.
It's one of the reasons why we don't typically label things like anxiety in a cancer trial. It may be obviously something for where anxiety is actually the disease, but there's so many non-drug influences to anxiety. Sleep, for instance. Financial toxicity we don't look at all because their drugs aren't even being paid for in a clinical trial. So some of those concepts that you're referring to are used a lot in NIH trials or in post-marketing trials to understand the patient experience once the drugs are marketed. But for our pre-market, those we look at a little bit less and focus more on the disease treatment-related symptoms.
Thanks.
Chuck? Yes.
Yeah, I had one question. You know, right now, where we're looking in the CD19 space, we're probably going to measure a lot of outcomes which is confounded by that these patients are previously heavily pre-treated. So what is the value of getting PROs in the setting right now when we, in the end, hopefully move these therapies more in the upfront setting instead of an autologous transplant for lymphoma or instead of an allotransplant for children with acute lymphoblastic leukemia? So I was wondering, you know, probably Dr. Bosch or Dr. Koch, how do you adjust for that?
Well, I would just say, in response to your question and also your prior question, that
Can you identify yourself first?
I'm sorry, Ethan Bash. Many of these PRO tools have been evaluated in populations with advanced disease who are highly symptomatic, heavily pretreated with multiple comorbidities, and have been able to delineate very clearly between arms when there's, when there's a real effect there. And so there are many examples of, despite the challenges that you allude to, where these tools perform extremely well. And that's because some therapies really improve the way that people feel, and some therapies really worsen the way that people feel. And many therapies do a little bit of both in different ways, and these tools are able to detect that. So I would argue that in an advanced population or heavily pretreated population, it's perfectly appropriate to use these tools. In fact, those are the settings in which these tools are most commonly used. Now, that said, I think, yes, you might get a crisper signal in an adjuvant setting or in a healthy population as you move therapies, more up front. But I don't think that that's a reason not to use it later on. In addition, you can collect a lot of information that's hypothesis generating for earlier.
I think that was not really my question. My question was, the side effect profile will be probably different. For example, giving these cells, since it's, living therapy in a patient who is heavily pretreated, you get probably more expansion, more neurotoxicity, etc. So then you have a very validated PRO set of data, but you in the end have measured heavily pre-treatment therapy with CAR-T. And then, so the question is, how will this data look like when the patients are not so heavily pre-treated?
Do you want to take that?
Yeah.
All right. Tag, you're it.
Tap in. Okay. Will go from Kite. So I totally agree with you. I mean, this is where I think the challenge that we're all facing across the industry, as well as our academic partners and patients at that point. You're exactly right. Let's just take CD19 as an example, right? In our trial, in the pivotal trial, and effectively third, fourth, fifth line patients, 2/3 of them already had B-cell aplasia because they had so much prior rituximab. And as we're continuing to look at the B-cell aplasia, which is one of the long-term questionable side effects about what that means for patients, how's that going to go over time? So you're exactly right. As we get to earlier lines of therapy, potentially we might see fitter T cells, fitter patients. And that's why, again, I defer to ZUMA-7, because why? That's in second line therapy with a randomized control trial where we are going to be looking at some classic PRO measurements.
Can I want to ask a question, and I think Dr. Shaw will actually be one of the people who will answer. She's raising her hand. So we've heard a bit about how this therapy is so effective, kind of like why do we need PROs? I've also heard among the comments from the panels that PRO should only be used as part of randomized controlled trials. I was hoping some of the clinicians who've used PROs in practice, not in research, could talk to some of the, not just the challenges, which we heard more about, but some of the successes of how they've been used and how they've informed clinical decision making.
Gunjan Shah from Memorial Sloan Kettering. So I think that while I can fully understand your questions of sort of timing and duration of looking at these PROs, that specifically to what we can do with them even from now is we expect, even if we continue to use them in these later line settings with several lines of therapy, that there will be several iterations of these CAR T cells, and we expect that future ones will be better than the ones now. And one of the things that we've been doing with the autologous transplants, and part of looking at all of this, is eventually you have a therapy that's safe enough that what you're really researching is how to decrease the symptom burden and how are you actually making a difference, that these are your primary outcomes, that it's safe to give, it's effective, we know that this works, but how do you make it better for the patients? How do you not need them to be in the hospital or not need to be in the ICU and that kind of thing? And so some of these measures are really for that. And so I think that partly to answer your question, having these at the baseline of sort of the first generations of these drugs being used commercially and on trials is helpful to then sort of inform the studies of the future. In the autologous transplant setting, one of the studies and one of the only studies that's really shown to make a difference has been an acupuncture study that we did with our integrative medicine colleagues at MSK, and we're able to show a difference in their patient-reported outcomes as a primary of decreasing fatigue and changing their symptom burden. And so I think that having this information is valuable over time.
Paul Klutz, just one comment about late stage versus early stage. Most of our single-arm trials are in multiply refractory, our dose-finding trials particularly. And there's actually been some interest in using sort of side effect bother and side effect PRO to help better find dose. So that's one possible, actually pretty good utility for that. And I'd also argue that it's still important to measure safety, and it's very important to measure safety in that setting. And for instance, we know that in second, third line multiply chemo-treated patients, we're going to see a lot more neutropenia with another cytotoxic agent. And so I think we'll see, it's important to understand that toxicity profile, and I think I look at it as complementary to how we're looking at safety as well. With things like health-related quality of life, physical function, I may have to agree with you that maybe that's not the right spot for those more broad net benefit kinds of questions, but for safety, I think it's actually a pretty important use.
Ethan Bash, I'll just comment briefly on the real-world use of PROs. So our group and others have done many registries. We currently have a large national U.S. trial, or a study, I should say, real-world study supported by PCORI, in which patients receiving systemic cancer treatment for advanced disease at 50 community practices around the U.S. are self-reporting their own patient-reported outcomes on a weekly basis throughout their entire treatment trajectory. The compliance rate is 96%, meaning that if you look at the average proportion of patients who self-report at any given week, it's 96%. 80% of those are self-reporting on their own, and the additional 15 or 16%, they actually get recovered by somebody calling them if they don't self-report. So it's augmented by having a central person in addition to collect the information. I would also mention, there have been some questions about informative missingness when patients are hospitalized or have severe toxicities. And in those settings, we do use proxy reporting. So we will use a caregiver or a clinician who will provide the information, and that's generally used in sensitivity analyses so that we understand the reason for the missingness. But again, the missingness is extremely low, and these are patients with advanced disease, often close to death.
Dr. Parasinoto and then Dr. Ross.
Yeah, so I want to appreciate Dr. Sedana for mentioning the potential cognitive effects that happen to be particularly important to our Medicare beneficiaries. So my question is for Dr. Go or any other panel members in terms of the trials with the reported neurotoxicities, if we know the extent and the variability of the toxicities, if there was any cognitive assessments that were done at baseline on a follow-up, and what the long-term sequelae are.
We'll go from Kite. I'll comment first, and I'm going to ask our FDA colleague to comment as well. I think it's very challenging in terms of neurocognitive behavioral testing. What we did in Zuma 1 in the pivotal trial, we incorporated a mini mental status exam, which is not obviously a great obviously tool. We chose that because in previous FDA-approved products like blinatumomab from Amgen, they also use that as well. So that was sort of what I would say a very blunt tool to look at that. Obviously, we are exploring possibilities of other more complex neurocognitive testing, but this is, I agree with everyone here that as CAR-Ts go to other disease states, different lines of therapies, that this will be something that I think we would want to, as a community, to continue to support. And at Kite Gilead, we will definitely keep supporting that.
I'm Paul Klutz with the FDA, and I think it's an excellent question because I think I like these targeted questions that are getting at things that we know that are happening. Can we further describe and characterize the effect? Cognitive testing using is a clinical outcome patient-reported outcomes, obviously a challenge. If you're cognitively impaired, filling things out can be challenging, although there are some cognitive scales. There is interest in, again, looking at technology. So are there different kinds of gaming type of situations where you have a certain kinds of, almost a performance outcome where you're filling in certain things on an iPad, and there are some interesting things that are coming out with that, but we haven't seen that arrive at the agency.
Thank you.
Dr. Goss, and then Dr. James.
Thanks. I had a couple of questions. Dr. Bash, I appreciated your presentation because it was really very helpful. There were a couple of other, there was a question that I just wanted to clarify. The way our question is asked, it's not asked specifically about CAR-T at this point, it's just PRO. And in one of your conclusions, you made comment about their utility for CAR-T. And I just wanted to be sure that I'm understanding the question correctly, number one. And number two, to know if that would change how you're thinking about the use of PROs if it weren't specific to CAR-T. And I also had a question about kind of the pragmatic. So our question two has to do with, transferable to community practice and, quick throughput to a trial setting. And I was trying to go through the data that I had available. With the exception of the presentation on the FACT, which wasn't one of the measures we're looking at, none of them did anybody report what is a minimally important clinical difference. And so I'd be interested in our general assessment of the experts out there about which of these measures do we have kind of defined minimally important clinical differences that we can use as a benchmark. And also, there was some lack of information about the cost of licensing, for example. So EORTC, I think, has a license fee. It's been, you've mentioned it's a strongly validated measure, I would agree, but just curious if anybody has any details on those types of practical implementation issues, because they may be relevant to how we think about them.
We did report.
Dr. Bosch, please.
Oh, sorry. Sorry. Apologies. Ethan Bash from University of North Carolina. Yeah. So we did report on which tools were used in CAR-T trials, really just as a matter of information, but the basis for particularly use in community practice or how widely used the tools were. The generalizability came from use in the Medicare age population, and I did show that as a separate item for each individual tool, and that was the basis of that, not the use in CAR-T.
Okay. Any thoughts on the minimally important clinical differences and whether or not there are any of them that have really well-established guidelines or some that you feel that it may be missing for?
Yeah, so others can comment on this as well. So, in FDA lingo, this has been sort of changed to a score that represents a meaningful change. For all of the tools that I gave a smiley face to, there have been evaluations of what is a clinically meaningful score change.
Okay, thanks.
Yeah, with the caveat that the Pro-Ctcae is about adverse event reporting. That's generally descriptive rather than, comparison of proportions hitting a certain score threshold.
Okay, so I know there's a number of questions here. Dr. Lamont was next, and I'll just try to
I have
keep
a
going back and
question
forth.
for...
Let's try to keep the questions as short as we can so we have enough time.
Question for Dr. Snyder and anyone else who wants to answer. I really like the graphic presentations you did in the issues of getting clinician engagement in information. But I'm thinking about all the technological issues, and my impression is that the ability to do the PRO measurements is technology, that we have more information systems. How are you getting the information in those graphs? Are they in real time? And what's the interface with the electronic record that you're using at Hopkins or any other records? Anyone else wants to comment? I think that's limiting clinician involvement and putting a wedge between collecting data and using it. And do we have it in real time to use it in real time?
Claire Snyder from Johns Hopkins. Thank you for the question. For the purposes of our research, we made up the data, so it was really easy to get. However, the rationale behind the research was work that our group had done at Johns Hopkins and my colleague Michael Brundage had done in terms of clinical trial data, where we wanted to show the data to patients and clinicians, and we didn't know the best way to convey all the information we wanted to. How is the patient doing over time? What's an important difference? what is statistically significant, what does the doctor need to pay attention to. They're not going to learn all about these questionnaires. We need to make them immediately interpretable and intuitive. So the reason that we had to do the research that we did is that there is a huge increase in the collection and use of these data in clinical practice. So our team at Hopkins started doing this in 2005. I would say we were some of the pioneers in the US. I feel like we are now almost obsolete. But the work done by Ethan Bash and others has moved this so far forward where he is, for example, doing the study in 50 community practices. A colleague of ours, Roxanne Jensen, who's now at the National Cancer Institute, did a review of ePro systems in 2014, and even then, in cancer care alone, there were 33 unique systems meant for clinical practice. The big challenge now is getting the data in the electronic health record. With funding from PCORI, a group of us, including some folks here, developed a user's guide for how to integrate patient-reported outcomes and electronic health records. It is freely available on the PCORI website, and it walks step by step through all the considerations involved. It does not provide one right answer, but a range of options and their relative advantages and disadvantages. So I think increasingly there are tools that are going to get us there.
Great.
Thank you for the question.
Dr. Shah, do you have a quick?
Just very quickly, Gunjan Shah from Memorial Sloan Kettering. So I briefly was able to show you some of the figures from our MSK Engage platform that's being created and sort of in use on the surgery side and being transferred into a more long-term use for the transplant and cell therapy side. And you know what the way it's working right now and what we're hoping to continue is that you can actually pull it up in the office, that you can pull up in an individual patient and show that patient, here's what you've reported over time. And with one click, you can actually decide to include that in their electronic record. And so that it can be, you know, part of their record over time, but also pulled up in sort of a dynamic fashion to intervene on if you so choose to, but also see, you know, which things are higher at which visit, which ones are worse today, better today, and look over time. We, on the clinician side, can then also say, here's your entire panel of patients with the same disease or answered the same survey, and then have sort of more aggregate data also built in to be able to look at. And so I think it's kind of important to be able to be both ways, sort of aggregated across the population, but also to include the patient in showing them what they've reported along the way also.
Great, thank you. Dr. James, you've had your hand up the longest. Have you forgotten the question?
All those operational questions got answered in the last two.
Great, Dr. Feinglass?
For our FDA colleague, Dr. Klutz, how often does the result from a PRO assessment tool become the deciding factor for a binding FDA decision?
Thank you for that softball. This is Paul Klutz.
You're welcome.
Paul Klutz from the FDA. So I think it's a really important question, and it's something I actually was talking about over lunch, and that is, are we using patient-reported outcomes to further characterize how a therapy affects a patient in the totality of data? And then we organize that in a qualitative or a quantitative risk-benefit determination, which is what we do at FDA, mostly qualitative right now. Yes, we do that all the time. We wrote a recent New England Journal of Medicine article on the use of metastasis-free survival, which is a new endpoint for non-metastatic castration-resistant prostate cancer. So it was a novel endpoint, and in this particular case, patients normally don't get a therapy, and they're usually asymptomatic, and so it was like sort of a maintenance therapy question. So we were really quite concerned about the tolerability. This was an important part of our decision because we knew that the benefit was there, that it was pushing back metastatic disease, but how tolerable was it? And so in that case, we did look very carefully at this overall side effect bother question and different side effects and made sure that there really was no significant signal there in addition to the normal CTCAE data. So that weighed in. I think the bigger question is, have we ever used it for a negative non-binding decision? And I think that's obviously what everyone's really concerned about, and that's not to my knowledge. We've used it for important positive decisions. For instance, Jakafi, as I said, it was a key secondary endpoint that moved the regulatory decision from an accelerated approval, because it was a surrogate endpoint as a primary endpoint, to a regular approval because the secondary endpoint was a symptom improvement, a clinical benefit that was meaningful to patients.
Dr. Civic, I think you were next.
Yeah, one of the questions we're asked is how long to measure, a PRO to be able to identify a valid treatment effect. And, you know, we're looking at late toxicity, but also, I think it was Dr. Aberkoff who talked about late benefit, that there wasn't a response until, in some patients, until 9 to 12 months, which makes it seem like we should be measuring PROs for at least 12 months. Does anyone want to comment on?
Will Go from Kite. So yeah, similar to other trials in our pivotal trial, Zuma-1, we've actually seen that in a single dose of CAR T, and as well as at the NCI, and I'd love to hear Dr. Yang comment as well, that we've seen conversions from stable disease to PR to complete remission as late as over 12 months. And this is why, and without any other intervening therapy. And so this is why, again, I'm not a PRO expert, I'm a hematology oncologist, but if I were to design the PROs, again, that's where the challenge lies, because you're going to start seeing potentially late converters as far as 12 to 15 months.
Corey Abakoff from Novartis. I agree. It was my point that we do see these patients progress over time, and that is one of the things that differentiates CAR T therapy from other therapies. And I also am not an expert in PROs, but I think that this, along with the questions that have been raised about things like neurologic toxicities, these are still fairly young technologies, and they've been studied for a fairly short period of time. So understanding what those late effects are and how that impacts PRO measurement, as well as understanding the immediate effects and how that affects PRO measurement, are still things that we're trying to understand, and why we are actively utilizing them in our current and future clinical trials, because they will help us to answer those questions.
Merav Bar from the Fred Hutch. Regarding the long-term follow-up for PROs, I think there is two sides of it. One is the one that patients might respond later, but on the other hand, there is still relapse disease or progression disease after, and a lot of patients that we are looking at receive subsequent therapies that may also affect how they feel, their quality of life and symptoms. So there are the two groups of patients, that ones that maybe respond later. On the other hand, there are still patients who will have progressive disease and relapse after, receive additional therapy. They have symptoms because of their disease progression or because subsequent therapies. So these two things need to take into consideration as well.
Great. Dr. Garrido, I think you had your hand up next.
So from Dr. Snyder's presentation, we saw that individuals, including clinicians and researchers with quite substantial education, aren't so great at reading graphs and interpreting changes in PROs. So I'm wondering, either in your own personal experience working with patients with limited literacy or education, are people able to understand just the questions themselves, not even the changes? Or have these been evaluated in people with limited literacy or education?
Sir Pisadana, Mayo Clinic. While I don't have the exact answer you are asking, I had a patient who was filling out a similar questionnaire on our study. He did not have neurotoxicity, but he was in the ICU because his heart rate was fast. But he had not slept because of all the alarms going off in the ICU. And that patient had to read a question 3 times on that questionnaire to understand. Now, I don't know what to do with that answer. Do I even trust the answer the patient gave? So yes, those are challenges, not only of patients understanding questions, but even well-educated patients who are having side effects of treatment, being able to answer them in the state they're in. The one more point I would like to make from before is, I think it's important to study late effects because, as you know, for allogeneic transplant, we found out there are late effects like chronic graft versus host disease that impact quality of life. Now, we don't know any about CAR T yet, but who knows what's going to happen when these people are like 3 years out, 4 years out. So I think it's important to study them. We just don't know what they are right now.
Can I just add to the question about low literacy also, because I think you'll be able to answer this if some of the pro measures have also looked at multilingual and multi-ethnic populations.
Yeah, absolutely. So first, thank you, Dr. Snyder. I'm Dr. Bash, Ethan Bash. Yeah, I need to get like a sticker on me or something as a reminder. Which speaks well to your question, in fact, right? I need to be prompted. So a couple of things. First, in looking at Claire's evidence, which, I think is there are terrific studies about, interpretation of graphics. We haven't applied that level of scrutiny to clinicians, for example, interpreting waterfall plots or Kaplan-Meier curves, or all the different graphics that we're expected to interpret in journal articles or in drug labels, right? So, people have trouble digesting data. I told Claire personally, I like the USA Today, simple graphic, I can get that, So, I think there's something to, simplicity and understanding graphical displays. But I think that, as Paul alluded to, we sometimes apply a greater level of scrutiny to these patient measures than we do to the metrics that we all take for granted every day. I just want to caution us not to apply a higher level of scrutiny. Regarding your question, so there have been many, many PRO studies done in patients with low education levels, low health literacy levels. In a study that my group conducted that was reported last year at ASCO and in JAMA, we had a very large arm of patients who had never used a computer before, and they were using a computer, and that population had low literacy and almost universally had less than high school education. And they were universally almost able to self-report. And actually, that group saw greater benefits from reporting PROs and having that information conveyed to their clinicians for management of symptomatology. So, as far as language, there have also been many studies done in groups speaking other languages. And I'd say all of the tools with the smiley faces have been linguistically adapted or into other languages using a pretty rigorous translation process that often involves both cognitive interviews of people. If done well, it includes people with different levels of literacy and education as well. So I'd say for the good tools, it's generally pretty good.
Just a quick follow-up to that. Do you regularly, I assume this may have come up when you evaluate these tools, to ask the patient how burdensome they find the tool that they're answering? So is that every single tool you have that question and you have the data from there to be able to say, well, this tool, we have a very negative response in this one, and I assume that would be true for as the patient progresses through treatment, they may have different responses to that as time goes on. And what do you see with those trends?
So I'm sorry, just maybe restate that. What is the thing that you're interested in knowing, patients' opinions about?
The patient's feedback of how burdensome they find the tool that you're actually using to measure their feedback.
Yeah, so we've done a lot of that. Others have. I think Claire has too. So we've done a lot of work with how burdensome people find questionnaires. There are a few people who find these questionnaires to be burdensome, just like they find going to get their CAT scan burdensome and their liver biopsy burdensome. Not that a PR instrument is similar to a liver biopsy, but many of the things that people do as a part of trials or care is burdensome, but may have value. The vast majority of patients are very enthusiastic to do this. In multiple surveys we've done, on average, about 94% of people say they would recommend doing this to others, they would want to do it again, they find it highly valuable, it improves communication with the care team, they feel that they're an active participant in care, an active participant in the clinical trial enterprise. People feel engaged, people like doing this. I'd say that in some of the settings where we do studies where we ask the people the same questions week after week after week after week, there are people who push back, like, couldn't you come up with a few new questions? Or like, I already told you that I don't have fatigue. Why do you keep asking me about fatigue? And this is where we're starting to use technologies to try to make things a little more user-friendly. But in general, people don't find these things burdensome at all. In fact, quite the opposite. Most people are delighted to be, a part of what we're doing.
Dr. Flynn?
Yeah, Catherine Flynn from the Medical College of Wisconsin and CIBMTR. Just one additional point. I can't speak for all of the measures, all 7 measures, but certainly for the PROMISE measures, one of the stated goals in developing those was to evaluate every single item in people with low literacy. So every item at a minimum had at least 2 people with less than a 9th grade reading level evaluate the item through a cognitive interview. I think the Pro-Ctcae also had cognitive interviews specifically targeting people with low literacy. So for those meticulously developed measures, I think you can have confidence that most people will understand them. With those modular approaches, of course, that's where, taking into consideration how many different domains, how many different questions you're choosing, and testing that again to make sure in that particular patient population you're not asking something that people can't complete. But then another question you had asked earlier about licensing fees. Also, both PROMIS and Pro-Ctcae do not have licensing fees associated with them, so they're free to use. Thanks.
Hi, Karen Chung from Juno Celgene. Just addressing again the literacy level. So most of these instruments that the 4, the 7 that would move forward, they're built to be 5th grade kind of education level. So hopefully we're trying to take care of the literacy by making sure that the language is really understandable. With regard to understanding the outcomes, some of the analyses that we really try to do so that it's understandable to clinicians as well as patients include responder analyses, so they know, well, this is the proportion of the patients in the clinical trial who had a clinically meaningful improvement or, worsening or stabilized. So those are the kind of metrics we feel help them really understand the outcomes more than kind of what is the mean change from baseline, and the other kind of, modeling that we do on the PRO data. So, it's all trying to be very kind of, very concrete in the level of change. And someone had asked a difference about responder or minimally important difference. And there's a lot of people have done analyses around that. There's anchor-based, distribution-based. And for the EORTC-QQ30, we felt very comfortable using that because there have been solid MID research done out there by ASOBA, and so that's what we're using to define our responders.
Dr. Chang, you had a question earlier. Do you still want to ask it? Yes. Oh, sure.
Sorry for the delay. I saw a nice lineup of people here, and I thought I would wait to see what they had to say
Just
before I
introduce
jumped up. My name is Ilya Ferrucci, and I'm from Novartis. A lot of good points have been covered here. Standard practice when developing instruments is to develop them at no more than 8th grade reading level. And I did want to address one component, whether all of the items are relevant. I can't remember who had asked the question, but for instruments that are developed as standalone instruments, so I'm not talking about something like an item bank where you pick and choose, but where something like the FACT-G, for example, has been developed and has domains within it. When cognitive debrief is done, so a first draft of the instrument has been developed, and the cognitive debrief is taking and sitting down with a patient in that population. That's a really important part, is you're talking to real patients who have the disease condition of interest. And you ask them to work through the items and tell them how they're interpreting this, how they understand the response options. You also would typically go through a practice of asking, is this relevant to you? Do you feel that any of these items are repetitive? And that's a very purpose-driven process that we go through to ensure that we're not asking too many questions and the fit is just right. So some instruments like the instruments that Dr. Bash has actually summarized their development, and he talked about content validity. If you saw a smiley face or a check mark next to content validity, that's some of what he's talking about.
Thanks. Dr. Chang.
Sure, Dr. Chang. I still need some clarification as far as what the concerns are about collecting patient-reported outcomes. And I guess my question really is, there seems to be a lot of concern about using PROs in following how patients do. Do you have another suggestion then for collecting quality added life years? Or how do you really assess things like minimally clinically important difference? And then really, how do you risk adjust without collecting this data, the results of your patients? And then how do you then coordinate whether this is related to an episode of care versus fixed time points? And I guess that's what I'm saying, because all the concerns about PROs seem applicable through all of medicines, whether it's a stroke or spine, any tertiary center, would seem to have the same concerns that you have about follow-up and patient care. I'm just still kind of trying to figure out, how does this apply directly to CAR-T? And are you saying that we shouldn't be collecting any of these PROs for anything we do, or quality added life years are not as important? So I guess I just want some clarification on
Surbi Sadana, Mayo Clinic. I think it's very important to collect these data, and that's why we are doing them. I think what's not clear is exactly which ones. Again, we don't want to burden our patients too much, but we also want to get the answers right. What is important to collect, and then how frequently do we need to collect it? Do we collect it every week for 1 year? Do we collect it every month for 2 years? Like, when are we seeing the changes? I think that's the finesse we need to get right, but it's very, very important to collect. And I think the third part that no one really talks about is who's going to pay for it? Because right now I'm doing a study that has only 30 patients we need to collect. It takes one patient 1 hour to fill that questionnaire. Each patient will fill out 7, 8 questionnaires, so that's a lot of time for the coordinator. And once that patient goes home, someone has to call that patient up, or if they're filling it electronically and they don't answer, someone will be asking that questionnaire over phone to ensure completeness. And if they've gone away from my practice and now they're seeing a local clinician, and if they report a symptom, even if I see it, what do I do about it? Say they say they're having severe pain on that questionnaire. Now, I'm not following them on an everyday basis, so that creates an ethical dilemma as a clinician. I don't know what the right answer is, but I think it's very, very important to collect them. But in some way, as a community, and we were already talking about forming a working group, how do we answer these questions? Like, what do we do about the data we get, and who pays for it, and how do we collect it in a standardized manner? So we're collecting the things that are important.
Thank you. Just in the interest of time, try to keep your answers moving when there's a long line.
Karen Chung, Gina Celgene. Completely agree that patient-reported outcomes are important. I think it's important to assess them in a systematic way, and so that's why in clinical trials, we have, very good kind of follow-up to all these, rigorous schedule of assessments. If they go off study, we have one last assessment. I think the concern is really, if we had it in the real world, that would be great, but I don't think the infrastructure is there. I don't think, there's a way of getting this data systematically and cleanly. I mean, we have learned from a lot of, trial and error in clinical trials, a lot of issues with data, getting the data collection right. And so I think to, have the general practices, pulling this data together in a meaningful way so that we can use it is still, we're a little bit far away, with regard to that and all the other issues with instrument selection, analysis, and all the logistics around it.
Just want to give a clinical perspective as a former transplanter, as a former allogeneic stem cell transplanter. CIBMTR has been obviously the biggest group that has been for all mandated by law. That took them over almost 20 to 30 years before we actually really understand GVHD scoring. And so I think it takes about 20 to 30 years to even get GVHD scoring right. I think our opinion is that it's going to take a long time to really get PROs right correctly. And this is why from Kite Gilead, we don't believe that right now it's warranted in terms of coverage analysis.
Ethan Bash, University of North Carolina. Thank you. I have to say I came here today, I was very, very surprised, as you might be, to hear the reticence on behalf of some stakeholders to collect this information that cannot be gathered any other way in a population that we are bringing back to the clinic all the time, harvesting from, reinfusing, scanning, et cetera, et cetera. We are spending a lot of resources on this patient population, and to not collect patient-reported outcomes, which is essentially handing somebody a questionnaire, to me, frankly, seems rather absurd. There's a many-decade experience administering questionnaires to people in trials and in the real world with very high rates of compliance. There are all different kinds of ways to do it. It can be done on paper. It can be done with a telephone survey system. It can be done with an iPhone or an Android system. This is done all the time. There are hundreds and hundreds and hundreds of registries in oncology patient populations with 90+% compliance rates using electronic devices all over the world now. And to say that feasibility is a barrier, to me, is simply refuting an enormous amount of accumulated knowledge and ability. To the 45-minute or hour-long questionnaire, I mean, that seems very unusual to me. Our questionnaires that we use repeatedly take between 5 and 10 minutes long, and we often ask people, to your question, did you find the questionnaire burdensome or too long? I mean, it's really never an issue. There are some trials that have longer questionnaires that are spaced out maybe every 3 months. But again, I mean, to me, compared to what we are asking patients to do in order to receive these therapies, this is minuscule. So I don't really see the barriers.
Can I ask a follow-up to Dr. Bash?
No, well, I want to let her speak, and Dr. Yang has been waiting for a long time. I just want to make sure everyone gets a chance to ask.
Thank you, Ilya Ferrucci from Novartis. I think many valuable viewpoints have been expressed here. What I would like to add is that PROs generally, yes, are a great thing to measure, to understand ultimately how the patient's experience is going. But what I want to bring us back to principles and make sure we're focusing on why we're asking PROs. What is the research question? What is the context in which, because the answer to that question, which measure to use, is going to vary depending on what you want to measure and what the context is. So in broad strokes, it is hard to answer that question. And our position, I would like to clarify, is simply that we are not comfortable with PROs being required as a requirement, for coverage or access to a medication.
Great. Dr. Yang, do you still want to ask your question?
This is a question addressing the fact that almost everything we've talked about here today is about capturing acute or on-therapy toxicities or underappreciating them. The main difference in my experience with CAR-Ts, especially CD19, is it's a one-time treatment, and the back-end patients who are responding or doing well, which is almost half of those patients or more, have a paucity of any interventions or requirements at that point. And are we capturing that? So do any of the people who have PROs associated with their studies have questions such as how many people have gone back to gainful employment, how much medical care have they required in the last year or two, and how often do they think about their disease? How often do they have concern or anxiety about their disease? Because it can be a one-time treatment and then a walk away.
Will Go from Kite. So we are looking exactly into that, Dr. Yang, in terms of the work productivity and activity impairment version 2.0 in our randomized phase 3 trial. I think that's the biggest thing we're doing, because we're actually looking at that in all of our trials. This is mandated by the FDA for 15 years follow-up. So we are going to get the adverse events, looking at the B-cell aplasia, the use of IVIG, as well as some of these other PRO and back-to-work products.
Leah Ferrucci from Novartis. To answer your question, no, we are not collecting return to work, but the work productivity activity impairment questionnaire is a very good tool for that. I would say that we are using, again, the FACT limb, which has physical, social, emotional, and role functioning. So as a component of role functioning, we can certainly look at a return to normal activity, and we are continuing to collect that data 12, 18, 24 months after their administration of CART in Juliet.
Mr. Frankel, you get the last question of the open.
Sorry, to answer this question about the long-term follow-up. So yes, an effort has been made and will continue to be made to learn about those effects and long-term effects. Currently, we don't have the data. CAR T cells clinical trial started about maybe 5-6 years ago. So the data that we have right now is limited. And I think in the first few years, the most excitement was about whether the treatment works or not, what is the response rate, and people paid less attention to more long-term effect and quality of life. However, now when we know that maybe there is approximately 50% response rate and long-term response, so people paying more attention to those quality of life questions, and we are planning to follow up patients at least yearly for 15 years from now, according to the FDA requirements. So we are making an effort to learn that, but we still don't have data. And the thing that I would like to say here is that effort has been done, and we will make more and more effort in order to learn those questions. The question is if we need to make this a mandatory thing when we make the decision whether or not to reimburse patients for such treatments.
This question is for Dr. Bash and Dr. Klutz. Do you advocate for PROs to also be given to patients that were receiving the standard of care until now? So in other words, as a patient, I think that many would be interested to know how are patients faring in terms of their observation of their own outcome when they receive CAR-T therapy in this specific instance, and how are the patients that did not undergo CAR-T therapy and have a, let's say, 3 to 6 month survival on average, how did their feedback look? And that way you can actually compare those two groups of patients. I think that that would probably influence many patients much more than if they only saw receiving the therapy and they saw the drawbacks there, let's say, if they're looking at the advantages and disadvantages, and they can actually compare that to the alternative. Because I think without that, the patients are really at a very weak position to really have a fully informed decision.
Paul Klutz from the FDA. So I think one of the issues is context, which I was talking about a little bit earlier, and that is this a single-arm trial or is this a randomized trial? I mean, you won't have that. Comparing to a historic control is obviously going to be very challenging in this field right now, given the heterogeneity of the tools that are used and assessment frequencies and things like that. And so really when you compare to the standard of care, you're talking about a randomized trial, much like the one that was actually provided as I guess, the second-line trial that was presented. Now that you could do that, and in fact, that's the majority of what we get at the FDA in oncology is randomized trials, and they do ask the same questions of both arms, and that does help to give you a comparison of how they may feel or function on one arm versus the other.
And how about moving forward? So in other words, those that, for whatever reason, either they're not eligible or they opt not to go for the CAR-T therapy, maybe they're concerned about certain toxicities involved, capturing the data from those patients so that the patients that in the future have to decide between the two can have that at their disposal.
Yeah, that may be outside of more of a regulatory question, but it is an interesting question, and I don't know how you would design that, but it doesn't seem like something we would normally see in the regulatory setting. I did want to actually add one more point to the point of have people ever used at the FDA patient-reported outcomes to make a negative decision. Let's remember that in oncology, we have objective tumor-based measures, and survival is our primary efficacy measures, and we always have. In many other therapeutic areas, that's not the case. So I don't want to speak for the entire FDA by saying we don't use patient-reported outcomes in a very important way to make key efficacy decisions, because that's actually not true. There are many therapeutic areas where the disease manifestation is only a symptom. That's the only thing we can measure, and analgesia being the obvious example. But in those cases, you need to show that patient-reported outcome is improving, or that therapy is not going to show efficacy.
So at this time, oh, you should.
I was just going to respond to the question briefly.
Just introduce yourself.
Ethan Bash, University of North Carolina. Man, it's tough. I know, right? Seriously, need a mini mental size. So the most valuable comparative data will be from a prospective randomized controlled trial. That's one of the reasons why it's really important, for sponsors and in their discussions with regulatory authorities to really think about these outcomes and picking them right at the very beginning so that we can really understand in that context, because, we have a little bit more equipoise in that setting. I think your question really alludes to real-world settings, to registries and post-marketing surveillance, I would guess. I do think that there's value in having comparative data after a drug is on the market in order to do comparisons, especially if that information was not really fully characterized pre-approval, or if they're not long-term outcomes prior to marketing. That said, there are limitations. There are many dimensions of selectivity, patient and provider selectivity, and so those populations will inherently differ. Those who did and didn't get the therapy of interest, in this case CAR-T, and so if that was done, then there are methods for balancing those differences in observational data. It would just have to be done very well.
So thank you to the presenters again and speakers for continuing to answer our questions. So let us go about 10 minutes over. This was obviously a very rich discussion. Many of the panel members had questions. We're now supposed to transition to the period where we have an open panel discussion. And I just will note that we are not precluded from asking the speakers and presenters additional questions. But if you are asked, I would just request that you keep your answers very short. But this is really an opportunity now for the panel to ask, to further discuss the area, to think about in anticipation of the voting, which is going to be in an hour from now, what further information we need or that we still feel uncertain on.
I would.
Dr. Gross? Oh, and then.
Okay.
Go ahead.
Yep.
Go ahead.
I would like to circle back to two things. One is really the duration of follow-up. Some have mentioned the FDA mandated 15 years, but that really comes out of the gene therapy arena to look at the risk of insertional mutagenesis after the transfer of genetically modified T cells. So the question is really, how long should we really follow up these patients? And the other question is, or kind of comment is, right now there's no clear approved test to track the commercially products, and I would encourage the companies to develop those, because if in our PRO assessment something come up, of course you want to know what is the precursor frequency, or are there still measurable CAR T cells, and that is not right now available outside the research setting. So I think that probably is another key thing we really need to assess the safety and long-term outcome of these cells.
And can I just ask Dr. Gottschalk, are you asking that question to the panel to say, clinically, what's the appropriate time?
What is the appropriate time? How long, to panel or speaker, how long should we really follow these patients?
So basically, from what I understand, from what I heard, that's why I was kind of, like Dr. Abakoff mentioned, that 54% of patients went from partial to complete. I assume the symptomatology would also follow the difference between a partial versus complete remission in 9 to 12 months, which means it would seem to me that you would have to follow at least 12 months in order to get, and that was the question I was asked before. So if it's a question about the 3 choices that are listed there, it would have to be at least 12 months or up to 24 in order to see whether or not the patient's symptoms would follow the response rate.
Actually, I have a contextual question, because I mentioned it before, but I was wondering if Tamara could clarify for us. The way these questions are asked, they're not asked specifically about CAR T. I just want to be sure that's correct. So we're asking about PRO in the Medicare population, and we're asking about some specific measures, and then we're asking about, ability to implement. But nowhere does it say specific conditions, and nowhere does it say, the specific treatment. So we might have to think more broadly, and then putting a time. I understand for CAR T, 6, 12, or 24 months might be appropriate. For other situations, it may be longer. And so it may affect how we answer these questions. So I just want to make sure I understand the questions.
Do you want to add to this, Joe? So I do think it's broader than, yes, we didn't specifically say CAR T, so is it generalizable? But I'll also look to the team to see if they want to add to anything. Okay, I'm good. Yeah, so
okay.
You are absolutely right.
Okay.
Right, if that's the case, then it makes some of these questions challenging, like the length, the duration of follow-up.
Right.
Because if it's not disease-specific, the duration will then obviously change.
Yeah, and I think.
And most of these measures are PRO-oriented, so, or I should say oncology-oriented. So there's an implication there, but it's not direct. And certainly they wouldn't be relevant for cardiovascular disease, some of them. But the way we're answering some of these questions in that general sense, CMS could apply these recommendations, I guess, more broadly. I just want to make sure we know what we're voting on.
Correct. So, the national coverage determination that's open is CAR T.
Right.
But yes, some of these answers could, depending on what happens, could be, we might be able to use these more generally as we move forward in other types of technologies.
And that gets right to a question I have for CMS. Is the selection of the PROs then is ones that you have judged based on oncology? There's a whole host of others out there. AHRQ has developed a whole series of CAPS measures that are used for creating judgment on the quality of care that is being done to patients from their perspective. And the National Quality Forum, in turn, also has a contract with CMS in looking at promise for the development of quality-based measurements. Are any of those in play, or those future developments?
Those are not in play for this MEDCAC.
Yeah, I would actually then just kind of think that we are looking at this specifically for CAR T because, for example, if you look at PROMISE goes everything from, the PROMISE 10 that you can then crosswalk to EQ5D3L, for example, as a historical control to these other disease-specific measures. So I think when we're looking at this, unless we put it in context of oncology and specifically CAR T, it would be very challenging to make heads or tails of how to answer it because you can't compare PROMISE, for example, to MDASI outside of a specific context.
Yes, I think we should be encouraged to think about this in oncology for sure, including CAR T. I would keep us not like we shouldn't be thinking outside of the oncology space.
I would.
Yeah.
Just a comment, another thought that I had that I wanted to share with the other panel members is particularly when you think of a situation like CAR T. I was at an observer of the MEDCAC a month ago on a completely different therapeutic area. And one of the clinicians got up and said, one of the most important things for patients that they want to know is, what can I do to stay independent? And so on one level, PROs, everything is local and specific to an individual patient and what's important to them. And, being functional and independent and not a burden on their families or their caregivers is very important. And it seems to me that the patients who got into the CAR T trials didn't get there by chance. There's a significant selection bias issue where patients sought out treatment. They had nothing, they felt they had nothing else to lose, but not every patient with a cancer actually feels that way. And so some patients are willing to forego treatment and toxicity in order to be able to have peace, for whatever time they have left. And so I think there's a real, and the industry team, I think, did a very nice job of presenting your studies, except I don't think your findings from your trials are generalizable to Medicare per se because of that, number one. And so I think your notion that, well, we believe in PROs, but we're going to measure them in trials, I think is great and it's important, helps the regulators make decisions, but it doesn't generalize to what Medicare has to deal with in terms of whether or not these should be more broadly available. And so I think it's important, if you're not going to support this type of notion for going forward in some really systematic way, I think you'd be well advised in phase 4 studies to include additional PROs to help inform these questions that will inevitably come up again. Because I think, the population you've studied is a very slim, narrow part of the population who could eventually be trying to seek access here. And I think that's a concern.
Yeah, I just have a comment to make, and I think one of part of this conversation ought to be used as a brainstorming operation and how to do things better. It was mentioned that physical activity is a very important monitor for improvement. In my past experience, we were using a telemedicine experience in patients with heart failure, in Medicare patients, and usually just don't have heart failure. You have diabetes or hypertension or an abnormal lipid profile. And if you can get patients to invest, it doesn't make any sense to invest in your heart failure and not take care of your diabetes and not take care of your other comorbid conditions. So I think we ought to start thinking about the mobile technology that's emerging as an opportunity to track patients' improvement independent of peer patient-reported outcomes, which can be very subjective depending on time of day and how I'm feeling and how much pain I'm having, but may be a more a better tool to improve outcomes over a period of time. And it's stuff that can be transmitted electronically, doesn't require, you can decide whether you want to monitor on a weekly or monthly or bi-monthly basis. It's entirely so. I think we ought to start thinking about how going forward we can track patients' outcomes and responses more easily with better information.
I just want to add to what you said because, or to both of you actually, because my biggest challenge now as a clinician in geriatrics and palliative medicine is exactly this question when my patients go see their oncologists or their surgeons and they're trying to understand the risks and benefits and they're consenting for these procedures. And most of the time the data that's presented is around survival, is around dying in the OR. and very narrow-based things, yet what my patients want from me is to know, what is my quality of life going to be afterwards? And am I going to walk? What is my cognition going to be like? And so these tools, whether we use them to approve drugs or we use them at what part, it's important to just know how is this going to inform you as an individual person, and as clinicians to help me aid my patients in those decisions.
Yeah, I think a shared decision-making model would be really important
Novel
here.
idea.
And you know, honestly, it'll probably blow the minds of the PRO experts, but because if you think implementing a standardized PRO is hard, doing something like time trade-off and giving a vignette of what, you know, if you think about what cytokine release syndrome looks like and explain that to a patient and say, you know, here's your chance of survival, but here's what you're going to have to go through before you're feeling better. That might be even more relevant because that has to do with the decision to treat or not to treat, which is different than what do I look like 9 months from now. So just a thought, because it's a different set of concerns, but it could be very important to patients and to providers.
I don't want to harp on it, but when you treat those patients in a geriatric population, when it's presented to them, do you think that it's crucial for them to see the alternative paths? So in other words, if you hone in on one potential therapy and you discuss the risks versus benefits, and they say, well, they don't want to have these types of potential adverse effects. And then I think a key part of that discussion has to be, well, if you don't do this therapy, these are the quote-unquote adverse effects of not doing anything. And it's not exactly a pretty list either. So I think that if you don't give that list in a very clear and transparent way, then the patients are not really making an informed decision. They're making a very biased decision because they're only seeing the drawbacks. They're not seeing the optimal potential outcomes and the risks, in this case death, and a death that potentially can have a very challenging period of time until that point in the next few months.
Yeah, I think if you really look at a shared decision-making model, you're not really starting with these are the risks and benefits. It's starting with what are your goals and what are you hoping for. And if you start from that point, then you back into the risks and benefits of treatment or not treatment. So I think that absolutely you have to, you know, weigh the cases of, for example, you have metastatic GI cancer, and you can go through a surgery and chemotherapy and have significant toxicities and end up with, you know, a pouch after the surgery. And if without that treatment, you can also have a bowel obstruction. So it is looking at how you're going to die. It is also looking at limited life expectancies. And as we heard with these trials, you're looking at people already with limited life expectancies. And you do have to weigh both, but it is starting from the start, which we don't often do as clinicians, is saying, what are you hoping for? Because if someone tells me, I don't want to prolong my life, and I want to focus on quality, then that's a different thing than saying, I want to prolong my life at all costs, regardless of side effects.
Do you think that that answer can change depending on the data that's provided to them? So if a person says
Yes,
they don't want to
absolutely.
right, so that's what I'm saying I think is maybe critical over here, because you're dealing with the patient population where education is key. And that's what PROs are all about. It's to be able to educate the clinician and the patient alike. And if you're only collecting and emphasizing the data of the risks versus benefits of the new therapy and not very clearly articulating the alternative course, then I just think that patients are lost over there. I mean, in the context of patient advocacy, most patients, in my experience, want to live, and they want to live with good quality of life. That's the ideal. Then the question comes, well, if you can't have that, then what's the best alternative? And many times, if the best alternative is survival, it's, well, how's that survival going to look? Is it going to be a painful next few months and death, in one, let's say, example? Is it going to be a painful next 6 weeks, and then survival with a restoration of quality of life, perhaps with CAR-T therapy?
I'll just note that, sorry.
I was just going to say, this gets into the whole area of patient preference, which is really not addressed in PROs.
Right.
But is the next step up from that, because you can get informed information and share that with the patient, but without understanding what the patient's goals and what the family goals are, you don't have that preference.
Yeah, and I'll just also emphasize that the steps of shared decision making is not treatment yes, no. It's treatment path A versus treatment path B, and PROs are aspects of information that help inform those goals of care, they're not actually the shared decision making themselves, right? So we're talking about information that can inform the patient care plan in terms of what their goals are, what their objectives are, if quality of life is more important than mortality, or whatever the trade-offs may be.
I think that's the disconnect that I'm kind of seeing in here, is that we're talking about, you know, the quote-unquote real-world application, the real-world assessment versus the clinical trials and the inclusion-exclusion criteria, because we know that when we treat patients in a clinic, we don't follow inclusion-exclusion criteria as the way we do in clinical trials. And so maybe getting back to one of the discussion points was, are there other PRO assessments? I guess a question I would pose to the group is, are these too specific for cancer per se, and should we be looking at just a simple EQ5D to say, look, all we want to care about is what's the quality of life here of a treatment, something that's easy to do. EQ5D, I think it's hard to argue that that's an onerous add, but yet would give us a general health assessment whether or not going through a treatment or any type of treatment, whether it's CAR-T or lifelong IVIG, et cetera, how much effect did it really help? Because that's something that we can then talk to our patients about, the whole idea of a quality added life here. Crickets, never mind.
I think there are other measures that should be considered, for sure.
So I guess that's the question, is like, I know we're being asked to talk about these PROs, but is one of the concerns from everything we heard is that these are just too onerous to get on a regular basis for the data that we're getting out of it, and should we take a step back and just say, for example, for PROMIS, just start off with a PROMIS 10. Just start off with something modular that we can build up on, but still gives us the idea that, is this treatment really helping somebody, or are we looking at administrative or other variables that the patients may or may not care about?
I think there's a tension between finding a scale that provides useful enough information, but that is still going to be sensitive to changes after receiving a treatment. So we don't want measures that are too specific, that related to very specific adverse events that are only going to occur in a subset of patients for a subset of therapies. But if we go to too global of a measure, will we see any meaningful change in that after receiving some type of therapy, whether it's CAR-T or something else? I don't know the answer.
And also, I think that was mentioned a couple times, the burden of surveys and, you know, survey fatigue. And certainly, you know, I have patients that say, oh, I remember the 3 words from last time. I'm like, okay, I don't need to test your cognition if you remember them from last time. But certainly that part of what is a survey fatigue. But I do like one of the things that I think Dr. Bashi said in terms of the additional characteristics we may be looking at. So having some general health assessments and having a focus really be on function and physical health. I think, as I mentioned earlier, and clearly it's a struggle for all of us, how we measure cognition in a reliable way, both in terms of adequate measures and then self-report.
So I have kind of a related thing as a little bit of a committee process that, you know, we're looking at these instruments and we may or may not want to add more to our list at this point. But we've also talked about how this is a developing field and that there aren't necessarily, you know, there might be better instruments developed in the future or CAR-T specific instruments. So it's like choosing some, you know, 1, 2, 3, 4, or 7 of them now. You know, I'm hoping that's not going to preclude the addition of other instruments as they get developed, but it's not entirely clear.
Well, I can let CMS answer that. My understanding is that because it's part of the discussion questions, that they are looking for our advice on things that they should be considering in the future as well.
Mm-hmm.
Is that correct? Or not exactly?
No, I think that's, I mean, I don't think this is the end of this conversation.
Yeah.
And so this is what we have for today.
Dr. Yang?
You know, I see you could make these PRO instruments too specific or too general. If you make them specific, it has the advantage of being applied to the treatment you're talking about. If they're too general, you put the burden on the patient to decide their global assessment. And if they're nauseated at the time they're filling out the questionnaire, they're not thinking about the surgery they need next week or the IV they might need next week. They're thinking about this problem right now. So I see that as the problem in both directions then. And the other problem I have is when you're talking about metastatic cancer, for instance, the outcomes for solid tumors are all the same, so you're just discussing how much intervention, quality of life, and other issues. But if you're talking about a potentially curative treatment, who fills out the questionnaire for the patient who dies, and what do they put down? So I don't really know how you globally assess, then, the impact of the treatment if the other if one of the possibilities is you could get over this cancer.
Related to that, we have our question about the optimal duration, or how confident we are about whether we can get meaningful results if we look at a 6-month trajectory or a 12-month or 24-month trajectory of PROs. I'm concerned about long-term monitoring using PROs and survival drop-off, especially if we end up doing some kind of long-term follow-up of a therapy versus standard of care using a registry. So if we have patients who aren't able to answer questions either because of an adverse event or due to differential mortality in the two groups, it's going to make it very difficult to isolate the effect of the treatment, even with the best practices in observational data analyses. I run into this all of the time in palliative care research, where one of the main goals is improving quality of life. We're not trying to improve survival, but it's the people who are getting palliative care versus not, no matter what we do to try and make comparable treatment groups, they're so different that it's really hard to isolate the effect of palliative care. So just something to take into account as we're thinking about meaningful durations for looking at these measures.
Right, and I guess I would just answer, if someone passes away, then certainly functional outcomes are pretty irrelevant. So I don't think that's really a kind of good point. But I think one of the things we're really talking about is just the challenge of post-market surveillance of any treatment. And I don't think that's something that we can say isn't needed or is too hard to do, because the durability of any treatment is going to be pretty important irrespective of the field. And so I think from a larger standpoint, we do need to look for ways of assessing what is the durability and the long-term outcomes for our patients, and whether or not it's a short-term gain or a long-term gain does depend on whether or not we really want to put our patients through this overall. And so as a surgeon, if I do a surgery for a metastatic tumor, that sure, I can get them through it and they'll do fine for 6 months and still pass away, but boy, is that worth it if they have post-anesthetic issues like post-operative cognitive issues, et cetera. And I think that's the question that we're trying to answer here, which is there a surveillance tool, that we can use to assess whether CAR-T or other treatments have the durability of effect, or is it something that we follow for 3 to 6 months and seems okay, and then in 2 years durability starts waning, and whether or not that's worthwhile, or is it the IVIG that helps keep it in check?
And I also want to emphasize, particularly in the realm of post-market surveillance, right? We're not necessarily just thinking about these PROs as for patients who lived versus died, and how to then assess the missingness, but quite often this type of information, as new therapies come to market and other therapies get tweaked, right? It happens quite commonly in the medical device space. The devices themselves improve over time. You use this type of information to better understand symptom burden with the sort of iterative, the product over time, and comparatively across products.
In terms of the neurologic toxicities, which really goes hand in hand again with the question of how long to capture the data, I think that it was mentioned by Dr. Go and Dr. Ferrucci about 14 months or so, that Dr. Go mentioned 14 months in terms of seeing a complete response when there wasn't until that point. But what about in terms of neurotoxicity, how long did you see that at that point in 14 months, what percentage of the patients that had a neurotoxic effect did you still see at that point along the line?
Oh yeah. You get a question directed to you, you may stand.
We'll go from kites. So yeah, we are still exploring that in all of our studies, so we don't really have all the data right now. But in general, we only had, at that point in time, the data cutoff that we then filed with the FDA, as well as what we published in the England Journal. We had one patient with grade 1 memory impairment. So that's sort of what we're doing. But again, these are sort of crude measures as well. And so as I said before, we're trying to figure out how to do this because we are very interested in PROs as well as neurocognitive testing, so we're exploring those opportunities right now.
And how did you adjudicate which neurotoxicities observed were related specifically to the therapy versus just because of hospitalization that you see in a older population?
Where's my FDA colleague? Oh, he's gone. All right. I'm going to tap him in a second here. So this is exactly right. I mean, so obviously we do have attributions in our clinical study to, is it related to the CAR T therapy? Is it related to disease? Is it related to the cytotoxic conditioning
Or
chemotherapy?
just delirium because of an in-hospital experience.
Correct. So we don't have as specifics. That's all we're testing. All we ask is it related to CAR T? Yes, no. Is it and our new trials is it related to disease? Yes, no. And that's the only thing that we really have. It's very crude and rudimentary, but this is exactly the question to clinically, and as I used to practice, I mean, I get delirium if you put me in the ICU with all the beeping, you know, and when I was an ICU resident, so that's...
Was the neurotoxicity measured with a PRO and a PRO measure, or was it using like Barthel or
so
mini
this is
mental
why,
state or what?
yeah, sorry to interrupt, but this is why, for the second time, we did a mini mental status exam, because one, that was already been tested in blinatumomab prospectively. That's why if you're obviously you can't even do the mini mental status exam because you're in grade 3 neurotox. That means mini mental exams of 0. You know, so and that's why, you know, rudimentary. We went from a 27 to 30, which is roughly normal. For the patients who had grade 3 neurotox, went to 0 and then came back to roughly 27, 30. This is the challenge. We didn't do any proxies because obviously that's another challenge to collect that. And then to your point, though, this is why I think it's challenging, especially in the neurotox setting. The one thing we try to do for consistency is, number one, we use the CTCA 4.03. We collected all of it. We provided all of it, and this is the challenge because some of the neurotoxicities were at the time of death and clearly with patients who had progressive disease. So this is why this is a challenge because as a lot of people know, how do you usually die of leukemia and lymphoma? Infectious diseases, progressive diseases, and a lot of those times the patients are actually in an impaired neurologic state. And then I'm going to tap in my FDA colleague.
Paul Klutz from the FDA. Just the issue of attribution, I can't stress, is one of the most challenging factors in evaluating clinical trial data because of all of the situations that you've just mentioned. Disease can cause it, treatment can cause it, comorbid disease can cause it, and many times it's very complicated and challenging. And in fact, this is why we don't like disease-free survival as an endpoint, even though it would be nice and clean. When patients die, they die of it's very hard to tease out whether or not it was due to the disease or due to something else. And so the way we look at attribution is a randomized trial. If it was a randomized placebo-controlled trial, even better, but we hardly see those much anymore. So in single-arm trials, we just assume that for now, until we get more data, that it's at least possibly related to the drug.
Specifically regarding the neurotoxicity, so there is some data from our institution, and definitely patients that undergoing CAR T-cell CD19, they do have neurotoxicity. Patients who develop CRS are at high risk for developing a neurotoxicity, and there has been a trial that was published a few months ago from our institution trying to understand the mechanism that they cause the neurotoxicity. There is no clear answer, but there are some direction showing probably that there is some increased permeability of the blood-brain barrier that they cause to increase toxicity. However, what we found that the neurotoxicity is usually short-term, and even patients that develop neurotoxicity, patients with CRS and neurotoxicity, it's usually short-term, and patients do recover within a number of weeks. So when we started to look at long-term data of those patients, we did not see that patients that had short-term neurotoxicity have some cognitive determinant later. It's early data, and we didn't study that very systematically, but from the data that we have, even though patients have high risk of neurotoxicity, if they develop CRS, it's short-term and with no long-term cognitive effects.
Dr. Yang?
You know, when I think about the issue of mandating a PRO, I think of you have a purpose for that. You know how to use that information if you're going to mandate its acquisition. And I wonder how I would use that information if I was a clinician and had an infinite database on PRO information. I could present 13% nausea incidence to a patient, 5% severe, or I can say that 87% of patients don't have nausea. And I could say the same thing about almost every complication. And And then I would also have to integrate that with, you have a 30-35% chance of having a durable, complete response, And so I find the information is definitely helpful. It's very definitely useful, but I don't know how I would specifically apply it in a uniform, consistent fashion if I had it all.
I can respond to that to a certain extent as a patient, specifically as patient-reported outcomes would apply to CAR-T clinical trials, since I was in one, fortunately, about almost 8 years ago. There was one patient, actually two patients treated before me. We had no idea what was going to happen. But fortunately, I had two patients just ahead of me, and I was warned that I probably was going to get sick, and what these symptoms were going to be, and what to expect. And that really helped, because when I started getting sick, I went, yay. It's working. But it takes a little of the scary out of it, to know, okay, somebody else got treated this way, I'm reacting the same way. Makes me feel better. And again, whether it's percentages or just general information of here's what to expect, especially in clinical trials where the trial I was in, the only animals that have been treated were mice before the three of us. So there's not much data, but as that data grows, to be able to feed that back to the patient who is considering a clinical trial, I think is really important. And another piece of that is that I'm part of the LLS First Connections program. So I provide, to a certain extent, patient-reported outcomes to a lot of CAR-T patients now that we have two approved drugs. I'm getting probably a connection 1 or 2 times a month. And what the patients want to hear is, what do I expect? What's going to happen? I've read this. And of course, you have to be careful. You're not their doctor. But at the same time, it's so comforting to them to hear somebody else has been through this, they survived, and to know what they're going to expect. And when they run into those things, they say, okay, Doug told me that was going to happen, or my doc told me that was going to happen. I literally just yesterday got an email from one of my first connection patients that I had talked to probably 3 months ago. And she sent me a note. She said, I want you to know I'm through my CAR-T therapy. It was really a battle. She had a lot of neurological effects, but she said they knew how to treat them. She was rough, but I'm out the other side. I'm in complete remission, and it was really worth the fight. But she knew all that stuff going in. So it takes the fear away. And then I have one more comment since I have the microphone. We're talking about duration of follow-up. CART-19 is creating a whole new group of patients that haven't existed before. A lot of us don't have B cells. I get IVIG once every, right now I'm getting it every other month. I was getting it every 3 months. And we're feeling our way along. But to be able to continue, I'm almost 8 years out, as I said, so, but I'm still without B cells. So, and there's a whole bunch of folks coming behind me. So I think long-term follow-up is going to be important. And just one more comment about PROs and clinical trials. I get a little bit worried when I hear some folks expressing the fact that that may make it difficult to get some clinical trials started, or that it's going to slow down enrollment or whatever. And I certainly would caution CMS with regard to how it gets the requirement for PROs and clinical trials, how that gets applied, such that it doesn't get in the way of patients getting enrolled and being able to participate in clinical trials, because right now that it offers so much hope to patients.
That was very helpful. Thank you. Other questions from the committee? Or discussion points that they want further considered?
I think, when we talk about PROs and clinical trials, I think, there's a number of what I would call disconnects, because we're seeing a number of societies and national organizations develop their own registry effort to collect patient outcomes, whether it's in neurosurgery with QOD or Society of Thoracic Surgeons, et cetera. And so it seems that some of the concerns that were brought up before, like, for example, like data acquisition, I think REDCap is a fairly cheap or free tool. And so I think as we move forward, I think PROs are going to be something that is going to be captured, like in Washington State, they're already capturing scope over in Seattle on a regular basis, irrespective of whether or not it's a trial or not. And I think the idea of understanding what is the quality of the care we provide patients is going to be important, not just for oncology, but just for medicine in general. And I'm saying that I think the tide's going in that direction, where we have to be able to show the benefits of anything that we do in medicine, and whether we like it or not. I think PROs are probably going to be the best way to do that, because you can't do a randomized controlled trial for every single question we have in medicine, not realistically.
Dr. Ding.
One point that Dr. Bosch raised that I think we need to consider, and that is, as we're starting to talk in terms of what is being reported by physicians on adverse effects versus what comes out from a PRO, there's a gap. And how do we explain to our patients that gap between what's being reported to the FDA and what patients are reporting?
Dr. Feinglass.
I think everybody on this panel, industry included, would be the first to say that the patient's view is important. And at the end of the day, the patient comes first. None of us are here for any other reason than that, or I hope we're not. But I think the other piece surrounding PROs in general is the heterogeneity of the field, which in some cases the PRO is constructed to be different from another PRO on purpose. So I think what the panel has to make a decision on at the end of the day in answer to the questions to CMS are not specific to CAR-T. They are specific to, are PROs useful in the arena of clinical research? And how do they inform the decisions that we are going to make while we see patients, while we conduct trials, while we design treatments? So one of the things that I want to make sure we all remember at the end of the day is not only the number one thing that the patients at the end of this, the second part is, as we're considering the tools, they're heterogeneous on purpose in some cases. And how are we going to use that uniformly? Are they generalizable? Are they not generalizable? And I think what we've heard many of the presenters say today is they are meant to be used in very specific cases. They're meant to be used with care. They're not applicable to everything. And I think as we consider the questions, we need to keep that in the back of our mind.
Yeah, I was just going to say a couple last thoughts. I agree. I mean, the patient perspective is really critical, and I think it's really valuable that CMS is actually asking these questions and addressing this issue. I remember a number of years back, so some of the data we can get from clinical trials, and it's very useful, and obviously it's almost a standard, probably is a standard for FDA to require PRO endpoints or PRO data in oncology trials. And there's still, even with that, there's still some gaps. So there's opportunities to fill gaps. My recommendation to CMS is to keep asking these questions and to be adaptable and flexible. The field is in motion and it's evolving. And I think there's valuable information here that will guide decisions made by patients, decision made by payers on what's valuable and important treatment and technology. And I think overall, we would be well served to remember that when we don't have complete clinical information, PRO data can at least provide good color and give guidance. So I remember, it's got to be 15, 20 years ago, CMS issued a coverage determination on the NCP for treatment refractory seizures. one of the questions was, well, it doesn't cure the disease, why would we pay for this? And the answer is because it showed a significant reduction in the events, and there was a strong correlation between the reduction in events and patients' quality of lives. So it is a way to bring it back to patients, and that's really important for us to remember. So even if we don't have a perfect solution, it's worth trying to improve the field and make incremental gains as we go, rather than throw our hands up and say there's nothing to do.
Do any other committee members want to make any final comments during this discussion period?
I just want to echo a point that was made a little bit earlier, that I would be hopeful that CMS would, when evaluating PROs in general, not necessarily specific to CAR-T therapy, because I think it's broader than that. Dr. Basha noted that he was skeptical of the concerns of it being a barrier to implement PROs. On the other hand, I can't help but notice that that was a position that was being suggested by multiple stakeholders, both in the background materials we had, in the presentations today, and anecdotally, I've heard such a sentiment before. And I would hope that there wouldn't be any barrier to access for patients, because ultimately, as was just said, patients ultimately are the focus over here. And if there was a potential barrier for a hospital or clinician to providing the CAR-T therapy for a patient, or whatever therapy that might be, due to the lack of resources to implement the PRO, whether the CMS would have some kind of pathway in place that that type of concern can be processed and addressed, so that those patients wouldn't be detrimentally affected by a PRO being implemented, and that you would just get the gains from PROs and not that kind of unfortunate, unintended trickle-down consequence.
I think it's an important point to be cautious. I'd be very surprised if there was any hospital or facility in place that could perform CAR-T and couldn't collect PROs. It's just, I mean,
just based on what was presented. So
I understand. And I also just wanted to say, Dr. Goss, to my knowledge, and I think about it, I do not think PROs are required as part of an oncology approval or any other FDA regulatory approval. I know that our FDA colleague has left us, but I did just want to make sure that was correct. So we've basically chatted for an hour. We're a little bit ahead of schedule, but I think now is the time where we're going to get ready to call a motion to vote. Is there anything formal that has to happen?
So, not necessarily informal, but I just want to go on record. We are planning on doing this vote different than we have done it in the past, not in the voting, but just that they're not going to record it on their phones or with an electronic device. The panel will be saying their name and their vote. We will record it. You'll see it behind us. Just because we're doing this because we thought we might run out of time and there are 23 questions. I also wanted to go on record to say the official vote is the piece of paper that the panelists give us. So when we are done with this meeting, we will take those papers, we will compare with what we have here and make sure that it's accurate before we post it on our website. So before we continue, I want to make sure the panel is okay with moving forward on how we're going to vote, and that you'll say your name and give us your vote. We'll record it. It's supposed to be put on behind us. Are they? Yeah. Okay, good. So,
Can I ask one question
Sure.
on the ballot? So question number, are we going to answer each question and go through the vote on each question? Because question number 2 is contingent on the result of question 1. Is that an average of 2.5 for my scoring, or is it the average of 2.5 for the group scoring that we would vote on number 2?
Group scoring.
Yeah.
Okay.
Yeah.
And it's up to you and how, if you want to
Yeah, so I think
one by one or...
I think it'll be easier if we go one by one. I'm going to just read the questions from the beginning to make sure that we're all on the same page, give everyone a chance to sort of just think it through.
Could I get one other clarification?
Yes, of course.
Section 5, question B, the how confident are meaningful results studied in each of the following populations. When you talk about usual care versus protocol-driven intervention, is that a randomized trial you're talking about predominantly?
Correct. That's my understanding of the question.
Okay.
So on May 16th, 2018, CMS opened a national coverage determination analysis on CAR T cell therapy for Medicare beneficiaries with advanced cancer. As part of this NCD analysis, MEDCAC will review the evidence specific to PROs. We are seeking recommendations from the MEDCAC panel regarding how existing PRO assessment tools should be incorporated into future clinical studies, including future clinical studies on CAR T cell therapy. I think just I'll note, as a side note, we've discussed future clinical studies in the oncology space. I think we've come to that as an agreement or expectation that we're talking about oncology studies specifically, including CAR T cell therapy studies. The MEDCAC will focus on specific PRO assessment tools and important characteristics of a PRO assessment tool. And we are going to assess whether the scientific evidence supports a specific number of outcome assessments, study design characteristics, study duration, and suitable controls for applying PROs to health outcomes research. This meeting will explore these challenges. And just to note, MEDCAC panels do not make coverage determinations, but CMS benefits from their advice. So voting questions. For each voting question, please use the following scale identifying your level of confidence, with a score of 1 being low or no confidence, and 5 representing high confidence. It's a scale of 1 to 5. And I'll go one by one. Question 1A. How confident are you that the Pro-Ctcae, the patient-reported outcomes common terminology criteria for adverse events, is valid and generalizable to the Medicare population?
Al Sujay, I'm going to vote 3.
Joe Chang, vote 4.
Diane Civic, 4.
Telly Franco, 3.
Melissa Garrido, 3.
Can you excuse me 1 second?
Yeah, we're voting on A.
We're voting
We're
on
voting
A.
on A.
That's what I said.
Yeah.
Can we start from the beginning? Sure.
Al Sujay again, I'm voting 3 on question 1A.
Joe Chang, vote 4.
Diane Civic, 4.
Telly Franco, 3.
Melissa Garrido, 3.
Tom Goss, 3.
Tom James, 4.
Joel Lehman, 4.
Carla Bericinoto, 4.
Shami Feinglass, 3.
Steve Gottschalk, 4.
Doug Olson, 4.
Jim Yang, 3.
You good? Okay. Question 1B, how confident are you that the MD Anderson symptom inventory is valid and generalizable to the Medicare population?
Al Sujay, I'm voting 4.
Joe Chang, 3.
Diane Civic, 3.
Telly Franco, 3.
Melissa Garrido, 3.
Tom Goss, 4.
Tom James, 4.
Joel Lehman, 4.
Carla Bericinoto, 3.
Shami Feinglass, 3.
Steve Gottschalk, 3.
Doug Olson, 4.
Jim Yang, 4.
Okay. Question 1C, how confident are you that the European Organization for Research and Treatment of Cancer Quality of Life questionnaire, the EORTC QLQ-C30 core questionnaire, is valid and generalizable to the Medicare population?
Al Sujay, 3.
Joe Chang, 4.
Diane Civic, 4.
Telly Franco, 3.
Melissa Garrido, 4.
Tom Goss, 5.
Tom, you're following me. Tom James, 5.
Joel Lehman, 4.
Carla Bericinoto, 4.
Shami Feinglass, 4.
Steve Gottschalk, 4.
Doug Olson, 4.
Jim Yang, 4.
Question 1D, how confident are you that the University of Washington Quality of Life, UWQOL, assessment is valid and generalizable to the Medicare population?
Al Sujay, I'm voting 2.
Joe Chang, 2.
Diane Civic, 2.
Telly Franco, 1.
Melissa Garrido, 1.
Tom Goss, 1.
Tom James, 2.
Joel Lehman, 2.
Carla Bericinoto, 1.
Shami Fanglass, 2.
Steve Gottschalk, 2.
Doug Olson, 2.
Jim Yang, 1.
Question 1E, how confident are you that the patient-reported outcome measurement information system, or PROMIS, is valid and generalizable to the Medicare population?
Allison J, 4.
Joe Chang, 5.
Diane Civic, 4.
Naftali Frankel, 5.
Melissa Garrido, 4.
Tom Goss, 3.
Tom James, 5.
Joel Lehman, 4.
Carla Bericinoto, 5.
Shami Fanglass, 3.
Steve Gottschalk, 4.
Doug Olson, 4.
Jim Yang, 4.
Question 1F, how confident are you that the electronic self-report for cancer, SRC, assessment is valid and generalizable to the Medicare population?
Allison J, 2.
Joe Chang, 2.
Diane Civic, 1.
Naftali Frankel, 1.
Melissa Garrido, 1.
Tom Goss, 2.
Tom James, 2.
Joel Lehman, 2.
Carla Bericinoto, 2.
Shami Fanglass, 1.
Steve Gottschalk, 2.
Doug Olson, 1.
Jim Yang, 1.
And the final question, 1G, how confident are you that the Functional Living Index in Cancer, or the FLIC, assessment is valid and generalizable to the Medicare population?
Allison J, 2.
Joe Chang, 2.
Diane Civic, 1.
Naftali Frankel, 1.
Melissa Garrido, 1.
Tom Goss, 2.
Tom James, 1.
Joel Lehman, 2.
Carla Bericinoto, 1.
Shami Fanglass, 1.
Steve Gottschalk, 1.
Doug Olson, 1.
Jim Yang, 2.
Great. So before we move on to the next section of questions, each panel member does have an opportunity to state for the record why they voted the way they voted, or if they want to explain any of the thinking behind their vote. Is that what I'm supposed to say?
Yeah, that's fine.
Okay. Yes, of course.
Just for the promise, I noticed one trend that stuck out listening to the different stakeholders was that that was the common thread, I think, from across the board, where it was either, even those that were not very enthusiastic about PROs in general, noted PROMIS was recommended within that context. So there was, if I'm not mistaken, that had the broadest consensus amongst the speakers and different stakeholders today.
Do any other panel members have comments?
I think it's not only who wins, but whether they're adequate in and of themselves is equally important. So that, the range of your vote matters too.
Can you state your name for the record for that last comment,
That was
please?
Jim Yang.
Thank you.
And just one last quick comment, Tom Goss. For the Pro-Ctcae, I was concerned about the respondent burden there at 78 items and not really clear on how it's used. It sounded like people are using bits and pieces of it, and I think that when you cut something up that was developed as a whole, that undermines some of the validity, potentially.
Are we allowed to take comments at this point, or response?
If you want, go ahead.
It was actually developed as a library, so each individual item is validated individually, so it's not meant to be used. So actually the purpose is for people to use little pieces of it, anywhere between, 1 and, as many as are warranted.
What's your name?
Ethan Bash.
Thank you, Dr. Bowen. Okay, so four of the PRO assessments were rated as a 2.5 or higher. That's the Pro-Ctcae, the MEDCAC, is that how you say it? MEDCAC, okay. The EORTC-QLQ-C30 and PROMIS. Whoever invented PROMIS, they had a good thought in mind. Marketing in mind. So we now move on to question number 2. which is considering those 4 PRO assessments with greater than or equal to 2.5. We're going to vote whether or not those assessments, it says combined, but are we considering them independently?
Yes.
No, we want to
You want a
Is
yes
that
or
the
no
intention?
for each one? Yes.
Looking to the CMS
Wait,
team to make
wait,
sure that the
what? Wait,
wording
no,
was
yes.
not.
Oh, you want to use it as one vote? All right, for those.
It's one vote,
Speak
right?
up.
It's not four, man.
Because otherwise we need more
So we
time.
can use them all, so all 4 of those together. Yes or
In
no?
the aggregate,
Yes.
with all 4.
Okay.
Hey,
So,
Josh, can I clarify one thing?
Joe, yes.
Joe, sorry.
No problem.
Joe.
It's one question.
Can I, so my clarification
Yes,
is.
Dr. Feinglass.
Thank you. On age, and one thing we didn't discuss before is I believe many of these that we've now picked were designed for adults. And so when we're asking this question of not sensitive to difference of age, can we make an assumption there that we are not talking about pediatrics?
I'd say I don't think so, because one of the studies showed that even in the pediatrics, they were Medicare beneficiaries. They hit, some 25% of the patients had Medicare, presumably because they were disabled because of their illness. So,
So the reason I'm asking, because it potentially changes some people's votes, because if you're looking at who's sensitive to age, if they're only designed for someone over the age of 18, that impacts it. So I was asking, can we make, for the purposes of the panel and voting here, can we make an assumption that we're looking at focus on Medicare age?
Yes, I believe we should be making an assumption that we are considering their use for Medicare beneficiaries with cancer.
The other wording is, it says available, has available supporting evidence. I interpret that as any. You mean available or sufficient? Adequate evidence.
I think it's our job to say whether it's sufficient. So,
Right, so that, should that word be available or adequate? Available means any
right.
evidence.
How would the CMS team like to respond?
Any evidence.
Any evidence. Okay.
I'm going to need a new sheet.
Thank you.
I'm going to need a new sheet.
You can go ahead and
then,
cross them
like,
out.
for A, are we adding them all up, like, or each one has to stand on its own?
So it's a single vote.
No, I know that, but is it additive or,
well,
you know what I mean?
Well,
Or is however I want to interpret it?
Well, it is how the panel wants to interpret it, because the questions are the questions, but you're making a single vote, so
Right.
I think you're taking the 4 that you've done 2.5 or higher and saying whether yes or no collectively on that.
Yeah, so conceptually, it's a challenging exercise. We're to consider all 4 PR assessment tools and whether any yes, no, meet these criteria.
Yeah.
So, does the panel need me to restate the 4 that we're voting on, or is everyone on board?
On board.
On board. A, B, C, E. Okay. So, question A, the characteristic is the breadth of measures in emotional, social, and physical well-being. Yes, no?
Al Sujay, yes.
Joe Chang, yes.
Diane Civic, yes.
Telly Franklin, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Shami Feinglass, yes.
Steve Gottschalk, yes.
Doug Olson, yes.
Jim Yang, yes.
2B, quick throughput to apply to clinical study.
Al Sujay, yes again.
Joe Chang, yes.
Diane Civic, yes.
Telly Franklin, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Shami Feinglass, yes.
Steve Gottschalk, yes.
Doug Olson, yes.
Jim Yang, yes.
2C, transferable to community practice settings.
Al Sujay, yes.
Joe Chang, yes.
Diane Civic, yes.
Telly Franklin, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Shami Feinglass, yes.
Steve Gottschalk, yes.
Doug Olson, yes.
Jim Yang, yes.
2D, measures are not sensitive to differences in age.
Al Sujay with the clarification, yes.
Joe Chang, no.
Diane Civic, yes.
Naftali Frankel, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Shami Fanglas, yes.
Steve Gottschalk, no.
Doug Olson, yes.
Jim Yang, no.
Question 2E, measures are not sensitive to line of therapy.
Al Sujet, yes again.
Just a point of clarification, so this is a double negative, so we're saying it is sensitive to line of therapy if we vote no.
Right.
Then no.
Oh, wait.
Joe Chang, no.
No, measures
hold on.
are not sensitive to line of therapy.
Meaning it doesn't matter the line of therapy.
It doesn't matter which line of therapy they're receiving, the PRO is still a valid assessment. You're voting no, just clarifying.
That's why I'm saying it's a double negative, so I'm voting that the PROs are sensitive to a line of assessment by voting no.
Right.
Right.
If you say no.
But no, Joe
So
Chang,
if
no.
you say yes, you think they
Okay.
are sensitive.
Just making sure.
Diane Civic, yes.
No.
Naftali Frankel, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Shami Fanglas, yes.
Steve Gottschalk, no.
Doug Olson, no.
Jim Yang, no.
Okay, 2F, the measures are not sensitive to comorbidities.
Again, Al Sujet, yes.
Joe Chang, no.
Diane Civic, no.
Naftali Frankel, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Fanglas, yes.
Steve Gottschalk, no.
Doug Olson, yes.
Jim Yang, no.
Question 2G, measures are generalizable to study of combination of therapies.
Al Sujet, yes again.
Joe Chang, yes.
Diane Civic, yes.
Naftali Frankel, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, yes.
Carla Pedicinoto, yes.
Fanglas, yes.
Steve Gottschalk, yes.
Doug Olson, yes.
Jim Yang, yes.
And last question 2H, used in net benefit analysis based on symptom burden and well-being.
Al Sujet, yes again.
Joe Chang, yes.
Diane Civic, no.
Naftali Frankel, yes.
Melissa Garrido, yes.
Tom Goss, yes.
Tom James, yes.
Joel Lehman, no.
Carla Pedicinoto, yes.
Fanglas, yes.
Steve Gottschalk, yes.
Doug Olson, yes.
Jim Yang, yes.
Again, I'd like to open it up to give panel members an opportunity to explain their vote or any of the information they want to state for the record. Dr. Garrido?
This is Melissa Garrido. I used a very minimal standard, so if any of the PROs had any of the evidence, then I voted yes.
I would say Tom Goss, the same, and my assumption was that if in the aggregate, even one of them covered it, then the answer would be yes, so, because you could select from any or all of them.
And Tom James, with B and C specifically, we heard from some of the health systems that there were difficulties in those, but then we heard from others that they've been able to achieve those, so that's why I voted yes. I think it's possible.
Any other panel members want to make a comment?
One thing I neglected to state at the very opening of this meeting, which is probably obvious to all industry in here, but my comments reflect the overall industry point of view. They do not represent any individual company, mine included.
Stated for the record.
Steve Gottschalk, I just want to state for D, since I'm the only pediatrician on the panel, I think they are age sensitive and we need PRO measurements specifically for pediatric patients.
Okay. We have two discussion questions to address before we move on. Just to state to the panel explicitly, are there PRO assessments other than those listed in question 1 that have adequately stated evidence-based criteria and processes that you would want to raise to bring to the attention of CMS for further consideration? And are there additional desired characteristics other than those listed in question 2 that you believe should be taken into consideration?
They're not on the ballot, so.
Sorry?
They're not
They're not voted on. These are discussion questions to the panel members if people have responses.
So a couple of quick things. I would say, I think that the fact has been, this is Tom Goss, I think the fact has been used and it has a number of condition-specific measures that I think have been validated in a variety of cancer types. And I would also say that the EORTC has a number of tumor-specific add-on modules that I would encourage CMS to evaluate for their utility for specific conditions.
I would just make a comment that we need to look at the PROs in a context of the presenting episode of care. So for example, someone made an allusion to using CAR T therapy in the future for multiple myeloma, but if a patient, for example, had a pathological spine fracture and spinal cord compression or injury, they would certainly need a different type of assessment based on metastatic spine disease or their presenting episode of care compared to using what we're talking about today as well.
And Al Sujet, I'll just make a comment. I sound like a broken record, but I'm looking out at the audience. I might see a couple of millennials and no Gen Z around. So these patient-reported outcome tools have been developed by boomers and older. I think the technology is available to enable us to do a better job of collecting information. And I'll leave it at that.
Shami Fineglass, the two things I'd add are from a diversity and inclusion standpoint in clinical trials. One thing that was brought up by Dr. Bosch, whose names we all now know when he stands up to that mic, are the availability of language translations, I think is really important. And as you look at developing, those of you in the room who are developing more patient-reported outcome assessment tools, is there diversity and inclusion in the people that you're looking at when you're putting them and you're asking them those questions? Are those questions relevant to them from a diversity and inclusion standpoint? So to be specific, gender, cultural, where are these people from? What do they identify as? What are their languages? Can they actually answer your questions?
Tom Goss, I would just say, I would also suggest that CMS evaluate whether or not there are licensing fees for any measures they would recommend. I think there's some variability on some of these. And I would also say that it would be important as well that for any of these measures that they would consider, clearly the validated translations would be important, as already noted. And I think there was another one, I'll think of it and come back to it. Oh, respondent burden. I think you should always have a sense of what the time frame would take to complete it, particularly in oncology patients where at times they may be fatigued and having other symptoms. 7 minutes might seem like not very much time, but it could be a long time. And certainly like that 78-item symptom, if somebody would go through all of that, that would be, I think, hard.
Melissa Garrido, I would add an adequate variation in the responses, so an absence of floor and ceiling effects.
Great. If we have no additional comments, we're going to move on to question 3. How confident are you that each of the following assessment intervals are appropriate measurement periods for a valid PRO assessment?
Al Sujet, question 3A, answer 1.
Joe Chang, 3.
Diane Civic, 3.
Naftali Frankel, 3.
Melissa Garrido, 3.
Wait, pause, sorry. Are you ready? So we're talking about 3A, the variable event dependent frequency interval. Who's next?
I'm 1.
Yep. Garrido is 3.
1, 3, 3, 3.
1, 3, 3, 3. And Garrido's 3.
Yes.
Okay.
Tom Goss, 1.
Tom James, 3.
Joel Lehman, 1.
Carla Pedicinoto, 1.
Fineglass, 1.
Steve Gottschalk, 2.
Doug Olson, 3.
Jim Yang, 4.
Again, on a scale of 1 to 5, how confident are you? Fixed time-dependent frequency interval.
Al Sujet, 4.
Joe Chang, 4.
Diane Civic, 4.
Naftali Frankel, 4.
Melissa Garrido, 3.
Tom Goss, 4.
Tom James, 3.
Joel Lehman, 5.
Carla Pedicinoto, 5.
Fineglass, 4.
Steve Gottschalk, 4.
Doug Olson, 4.
Jim Yang, 2.
Okay, question 1, again, scale 1 to 5. How confident are you that a PRO assessment over the course of the following study duration identifies a meaningful, durable treatment effect with a valid PRO? A, 6 months.
2, Al Sujay.
Joe Chang, 2, but specifically for CAR-T.
Diane Civic, 2.
Tully Frankel, 2.
Melissa Garrido, 3.
Tom Goss, 2.
Tom James, 2.
Joel Lehman, 1.
Carla Pedicinoto, 2.
Fineglass, 2.
Steve Gottschalk, 2.
Doug Olson, 3.
Jim Yang, 3.
No problem. Hold on 1 sec. Okay, question 4B, 12 months.
Al Sujay, 3.
Joe Chang, 4.
Diane Civic, 3.
Tully Frankel, 3.
Melissa Garrido, 2.
Tom Goss, 3.
Tom James, 4.
Joel Lehman, 4.
Carla Pedicinoto, 4.
Fineglass, 3.
Steve Gottschalk, 3.
Doug Olson, 4.
Jim Yang, 4.
Question 4C, 24 months.
Al Sujay, 5.
Joe Chang, 5.
Diane Civic, 3.
Tully Frankel, 4.
Melissa Garrido, 1.
Tom Goss, 4.
Tom James, 5.
Joel Lehman, 5.
Carla Pedicinoto, 5.
Fineglass, 3.
Steve Gottschalk, 4.
Doug Olson, 4.
Jim Yang, 5.
Great. It was my mistake. I forgot to ask after question 3, so I'll do them together. Questions 3 and 4. I want to give panel members an opportunity to explain their voting, if they would like to state for the record anything they took into consideration. It's questions 3 and 4. Dr. Yang?
This is Jim Yang for question number 3. I interpreted that as based on the individual investigator in the study, that you could pick the cogent times at variable frequency intervals to assess this versus automatic fixed times regardless of treatment. Is that correct? Is that a correct interpretation?
Well, my understanding, and other members can contribute, it was that it's a fixed time interval as a sort of pre-specified at 1 week, at 4 weeks, at 8 weeks, not necessarily that you could pick it.
Not necessarily the same for every study.
Correct.
But the other one, that would be something where the investigator could decide what times were the most cogent ones for 3A?
Yes, the investigator would decide that this is the right time to ask the PRO.
But, so for 3B, I interpreted it could be like for the first 8 weeks, you do it weekly, and then you go to monthly interval. Is that correct?
That is correct.
All right.
Yeah, I interpreted it with the variable event dependent, and it's just that's the real world situation where a patient will come back to clinic at plus or minus X number of days or weeks based on the follow-up time.
So, I interpret this as Tom Goss. I interpreted that 3A as you define specific events and then you administer the PRO only when those events occur. And if the event doesn't happen, you don't administer PRO. So like at hospital discharge and then at recurrence of an event, say neutropenia, for example.
As opposed to at
set times, and these are representative times, but that in any given protocol for any particular study, the intervals would be defined based on the research question at hand. So it could, wouldn't always be weekly. Could be, could be variable, like at
as long as it's
3
fixed.
weeks, or, at 4 weeks, 12 weeks, 26 weeks, 52 weeks, kind of a thing.
Correct. People have any comments they want to make about question 4 or additional questions about or comments about 3?
Was yours on 3 or in 4? Mine's also on 4. Melissa Garrido, my diminishing scores with the greater time lengths reflect diminishing confidence that we can isolate a treatment effect from confounding factors over time.
On question 4, my concern was just the lack of data that's available at this point in terms of durability. It's still to be seen of the timetables that we're talking about, where we're going to see either positive or negative effects. So when we're talking about 14 months plus with dramatic potential responses, I just figured that a longer window of time at this point until we see data to say otherwise is a prudent approach. But obviously, we're basing our opinions on a real lack of data. So I assume that this will be reevaluated when more data comes in.
Can you state your name just for the record, please?
Naftali Frankel.
Thank you.
Any additional comments from panel members for the record?
Well, I based my decision primarily on that slide that showed a longitudinal course with treatment down and then over time up. So you have to monitor these patients over a course. And there's going to be a lot of variation among the patient population in their responses. So I voted for a fixed response.
And please just restate your name.
Al Sujay, I'm sorry.
No, that's fine.
this is Jim Yang. I'd just like to clarify again. I am not assessing this integrating all units of time equally. Like it was mentioned that with a longer time period, the effects would diminish if equally valued and weighted. That's not the way I was interpreting it. So.
Great. We're going to move on to question number 5. Again, confidence on a scale of 1 to 5. How confident are you that PRO assessments can provide meaningful results when studied with each of the following control populations? 5A, patient him, herself before and after intervention.
Al Sujay, 4.
Joe Chang, 4.
Diane Civic, 3.
Naftali Frankel, 3.
Melissa Garrido, 3.
Tom Goss, 4.
Tom James, 3.
Joel Lehman, 5.
Carla Pedicinoto, 5.
Fineglass, 4.
Steve Gottschalk, 4.
Doug Olson, 5.
Jim Yang, 3.
Okay, question 5B, usual care versus a protocol-driven intervention.
Al Sujay, 4.
Joe Chang, 4.
Diane Civic, 4.
Naftali Frankel, 4.
Melissa Garrido, 3.
Tom Goss, 4.
Tom James, 4.
Joel Lehman, 5.
Carla Pedicinoto, 3.
Fineglass, 3.
Steve Gottschalk, 4.
Doug Olson, 3.
Jim Yang, 5.
Then finally, question 5C, historical control.
Al Sujay, 1.
Joe Chang, 2.
Diane Civic, 2.
Naftali Frankel, 4.
Melissa Garrido, 2.
Tom Goss, 3.
Tom James, 2.
Joel Lehman, 1.
Carla Pedicinoto, 1.
Fineglass, 1.
Steve Gottschalk, 1.
Doug Olson, 3.
Jim Yang, 1.
Great, thank you. Does any panel member want to state for the record their thinking behind their votes? Please
I'll just
identify yourself.
Al Sujay. I'll just use my experience as a clinical investigator. In the all-hat trials, you had to have elevated blood pressure to be enrolled, whether you're on treatment or not. At the end of the study, 85% of our study cohort was at goal blood pressure. So I'm a firm believer in protocol-driven interventions.
Yep, Joe Chang, just for the historical controls, I think only a few of the PROs like PROMIS are able to be crosswalked to other historical things like EQ5D, and so I voted down low because some of the other ones we chose would not have an easy crosswalk ability.
This is Dr. Fineglass. I agree with Dr. Chang on that.
Great, so I believe we've come to the end of our votes. We now have an opportunity for our final open panel discussion of only 20 minutes. Each panel member has an opportunity to give their final remarks and has a maximum of 2 minutes. And you can just go in order. And you can decline, you don't have to take advantage of this opportunity.
No, I think this is my last MEDCAC meeting. I think I have to take a year break, but it's been a very interesting experience.
Don't forget your name.
Al Sujay.
I think Dr. Bosch left in the...
Participating in all these discussions because there's such a wide variety of opinions, regarding whatever the topic is that we discussed, and it's been very refreshing to be engaged and involved in it. So I want to thank MEDCAC.
Joe Chang, I echo that, and thank you for all the insight that you've given me across the various spectrum of this topic.
Yeah, this is Diane Civic. I really learned a lot today, and I'm glad I participated. And just in terms of my own experience in the questions, I think I really, put a lot more effort into answering that first set of questions and looking at the specific instruments. And I think, the other ones were much harder, maybe for a lot of us, and based on a lot less data. We all did the best we could. Yeah.
I'm Tully Frankel. I just wanted to, first of all, thank everyone for the great presentations and the great discussion amongst the panel members. The only thing that I just wanted to mention in closing is that when we were talking about patient-reported outcomes, that it's really in the singular, that we're talking about patients as individuals rather than a homogeneous population, because patients have independent needs and comorbidities and different responses. And it's very important, I think, that when discussing this general topic of patient-reported outcomes, we have to always focus on the patient as an individual rather than just as a population. And I trust that based on the conversations that we had today and the discussion, that CMS will take note of that when evaluating PROs moving forward, that obviously that it's going to be considered in that light for patients to be empowered with information as well as the clinician through that transparent process, but the patients can learn from each other, but with keeping in mind both from the clinical side as well as from the patient side that individuals vary greatly from each other. Thank you.
Melissa Grado, thank you to all of the speakers today for very informative and helpful presentations. I think improving PROs is a very worthwhile endeavor. I just think we should use extreme caution when trying to infer any causal relationship between PROs and the various treatments that may be considered.
Tom Goss, thanks for inviting me to participate. It's been very interesting, and I appreciated all the presentations made by the experts. They were very informative and helped us to really understand some of these issues in greater detail. I think our work is helpful, but probably not sufficient because there's some open questions remaining. So I hope CMS will remain open to adding additional information as it becomes available. But I laud the concept of really including the patient voice here in treatment decision-making and in trying to assess access to treatment.
Tom James, and this is my first MEDCAC, so I really appreciate the presentations and the opportunity to be here. We all come with our own experiences to this kind of a forum. As a primary care physician and as somebody who works within the insurance industry, I look at both individuals and at populations. But my experience working with Picker Institute, where we talk in terms of patient focus, not patient-centered, because patient-centered is being done to them. Patient focus engages the patient and their own preferences. This is a terrific first step, I think, for CMS in moving towards patient preferences.
It's been a pleasure being here. These questions ahead of time took me really out of my comfort zone, and I was very attentive as I could be today. I appreciate all the information. Just as an aside, as a practicing physician, I trust that medical education is still teaching physicians to treat one patient at a time, and all of this data is to help inform those decisions and that care. So I would make a comment to CMS or whomever that they, instead of leaning always on more data to the people giving services, we lean on the electronic health record people to deliver a record that will allow us to gather this data in a seamless way, to communicate with other, and so that we're no longer silos, buying all of this equipment that's replaced frequently because it's not adequate. We've defined what we need electronically. We ought to demand that it be provided for us.
Carla Pedicinato, I want to echo the comments by my colleague here about the EHR and the access to some of the information that we're gathering. It's a privilege to be here today. I'm very impressed with just the breadth of expertise, and I think that is what helped to have a a very balanced discussion coming from multiple viewpoints. I also want to acknowledge that it's great to include someone who specifically worked with older adults and in the palliative care world, so that would be me at the moment, but so thank you for including.
I wanted to thank the patients that are on this panel and in this room. It's important to have your view. It's important to ground us with that view, so thank you for your time and your efforts. In addition, I found it very interesting when we were talking to our colleague at the FDA about the fact that, at least in the oncology space today, we've heard that no PRO has been used to drive a negative decision related to oncology at the FDA. I thought that was sort of interesting as it informs how we move forward with this. Again, I think PROs have promise. I really promise, no pun intended there. I think it is a field that has more development to happen in it. We are encouraged in industry by the development of the patient-reported outcomes. As you heard here, many in industry have used PROs in their trials. We think they have a purpose. And as we see going forward with how these are used, we're certainly interested to see how this field moves forward. So thank you.
Yeah, I would like to echo the other panel members' comments. I also really enjoyed being here and participating, and I would like to thank also the speakers. I probably have 3 comments. First, my kind of take-home message is that PROs are probably not ready for prime time to be mandated for an experimental therapies like CAR T-cell therapy. And second, I would really encourage that we really take advantage of CI-BMTR, at least if you look in the stem cell transplant arena, that has been really the most robust database to glean outcomes, and the infrastructure is there. So that would be, at least for hematological malignancy, the starting place, especially since most treating physicians are transplant physicians of CAR T-cell therapy patients, so they're very familiar with data requirements and reporting requirements in this regard.
It's been a unique privilege to be able to participate in something like this today, and I certainly learned a lot, and it's particularly gratifying to hear so much focus on the patient and what that patient's experiencing. It's, as I say, gratifying to hear that.
I'd like to thank everyone who presented. I learned that PROs are extremely valuable instruments for acquiring information that cannot be acquired any other way. The follow-on is just as important, though. What interventions will eventuate, and can we demonstrate that those have benefit back to the patients who generated those data? And that's the piece that I'm looking for still.
Great, and I'll conclude by just extending my appreciation for all the panel members and speakers who volunteered their time today. Chairing a meeting like this is actually, it's quite exciting in many respects. It's the science of really 2 emerging fields coming together. The science of PROs has really exploded in the past decade, in no small part thanks to Bakori and the efforts of investigators like we have here today, as well as the science of cell-based therapy, which is in no small part to the industry colleagues who are here and the scientists at NIH who've spent decades doing this work. I think both are now sort of coming to the crisp of actual clinical practice, which is exciting for us. And now, as the general internist here, among others, and the geriatricians, we have to figure out how is this going to how can we best generate evidence that's going to inform decisions, not just in the very specialized treatment centers, but much more broadly. So appreciate the opportunity to be able to help steer the conversation, keep everyone on time. I like that. Thank you very much.
So let me conclude on behalf of CMS and the team, the National Coverage Determination team that's in the front row. Thank you. Thank you for your participation. Thank you for all of your comments. They are very appreciative. And Dr. Ctcae, let me tell you, you don't know yet this is your last MEDCAC because we may schedule another one yet and we haven't told you.
Sentiment won't change.
I appreciate that. We do appreciate all that you have done as well on your tenure here. And Dr. Ross, thank you for chairing this. This is your first MEDCAC ever, and we threw him in to the deep end to chair it as well. So, and you have done a fabulous job, so thank you for that. So just for next steps, very quickly, so this is part of our process, part of our national coverage determination process. I don't know if anyone has heard, but we've opened up a national coverage determination on CAR-T, so this is part of that process. You can go to our website to know, we have a tracking sheet of what the next step is, and our next step is the proposed national coverage determination, which is due in end of February, like February 27th, right? Many of you may know the date. So I think it's due, the proposed is due, I have several NCDs open, but I think it's the end of February this one is due. So it will be public on or before that date. So that is the statutory due date, and so we will meet that. The final then will be due 90 days after we make the proposed public. So those are our next steps. So now we're going to take all of this back. We're going to review everything that the panel has said as part of our analysis. This is one part, it's not the entire part. And we will then start drafting our coverage determination and make that public before the statutory due date or on the statutory due date. So again, thank you very much. And are there any?
I just need to collect, I'm coming around now to collect the pre-score sheets from all of the panel members.
All right, so with that, we've concluded. So thank you very much again. Safe travels, everyone.
Good luck in your
Thanks, Tom. I'm sure I'll get something. Let me